Okay, welcome to everyone. We can begin. I met Gerard 10 years ago in Vancouver, at the USCAP in Vancouver. And we met at a meal with Sharon Weiss and Jean-Michel Coindre. And every year we met us at the USCAP. So it was a fellow, and it's now a very well-known pathologist in soft tissue tumor and in dermatopathology. And it's a pleasure to welcome him in Paris. And we are excited to listen to all the cases. And we can ask your question after the cases for the presential and in the chat for the video conference. And Gerard, it's to you.
Bonjour, je suis Gerard Gardner. Merci de me voir invité à Paris. J'étudie le français depuis un mois, so, c'est difficile. Je parle un peu français. So the rest of the lecture will be in English. French is a beautiful language, but is very difficult to pronounce for an American tongue, but I'm going to keep working a little bit at a time. So it really is a wonderful honor to be here. I love France, and it's been a long time since I've been here, and especially to be standing here speaking just footsteps from where Pierre and Marie Curie discovered so much that changed the course of not just physics, but of modern medicine. And as a sarcoma pathologist, I see patients almost daily that have received radiation therapy. So very meaningful to me to be in such a historic place. The goal of what we will talk about today is practical. I want to show some common struggles that people encounter in dermatopathology and some soft tissue tumors, as well as a few new and evolving entities to make you aware of that have been recently described and we're understanding more about. Even for an American, I speak very rapidly, very quickly, and je suis désolé. But I am going to try to speak more slowly. And if I go too fast, you can tone me down a little, okay? I've been talking very quickly my whole life since I was very small. And but I will keep practicing. So it's okay, you can tell me to slow down. Because when I get excited about pathology, and then I talk faster and faster, so, okay. And I'm okay if you want to ask questions in the middle of the conference. We are a small group, but if you prefer to wait till the end, it is fine with me. I want this to be fun and interactive, and again, practical. I think much of the teaching that I do focuses on how to deal with difficult cases in everyday practice, because that's what I have to do, even as someone who writes papers and books. The struggle of figuring out how to deal with a lesion when the bottom of the shave biopsy is transected, and I'm worried, well, is there more down deeper that I can't see, and what do I say in the comment of my report? That is a struggle every single day, even after almost 10 years of practicing pathology. All right. So I posted unknown cases, which hopefully you got to see on online. So we can go through those. And if we finish early, I have lots and lots of other cases. So you can just tell me, I want to see an example of epithelioid sarcoma or whatever. And I'll pull one up and we'll talk about it, okay? You will get all 6 hours worth of lecturing out of me, okay? Just so you know. Okay, so this is case number 1, a 50-year-old man with an ulcerated papule on the nasal ala. So we have 2 pieces of tissue here. And you can see it's a papule. There's the ulcer with scale crust, bacterial colonies, very common for ulcerated skin lesions. And I think, obviously, how many of you see a lot of skin in your practice every day? So, okay, so only a few. So many of you do more general pathology and just occasionally see skin. So I was worried when I submitted the cases. I thought, I don't want them to be too easy and basic, but I also don't want them to be too hard and crazy esoteric thing that you'll never encounter. So I think for dermatopathology, one thing that's important, true for all of pathology, but especially for Dermpath, is to start at low power. Because if you go straight into 80 times 40 times objective, you'll find some atypia or a mitosis, and then oh mon Dieu, it's malignant, and you will be afraid. Don't be afraid. So look from low power first. And I think this part of the lesion here in the center looks very busy, very complex, scary, right? Looks like kind of like cancer to me from low power. But the bottom part of the lesion looks different. And I think that's the key here, is recognizing what's going on at the sides and at the base of the lesion. So let's go look in the middle first. In this area, there are basaloid blue islands of cells, nests, and also these cords or strands that are trickling and look infiltrative and invasive into the stroma. In this area, the cells have a more eosinophilic cytoplasm. They have a kind of a keratinized appearance, similar maybe to squamous cell carcinoma. I have seen squamous cell carcinoma look very similar. Probably a closer resemblance is basal cell carcinoma, when basal cell carcinomas are infiltrative or morphiiform, especially when they are ulcerated. They often become very pink and eosinophilic, and they begin to express more keratin, and that gives them a keratinized appearance. And the background has a blue myxoid change and reactive spindled fibroblasts, the kind of stroma that we often see in basal cell carcinoma. So on a small biopsy of an area like this, it would be very easy. And in fact, I probably would look at that and say, infiltrative carcinoma, basal cell versus squamous cell, I don't know. And sometimes I do that on a small shave biopsy. Are shave biopsies common in France? No. Here, no and yes. So one thing, this is good. C'est bon, c'est bon. One thing I love about teaching different audiences all over the world is I learned that there's such unique differences in certain areas geographically and different systems of practice. And social media, as some of you probably know, I use Twitter and Facebook and YouTube, all of the social media a lot. And it's been great because I get to have conversations about pathology with people from Europe and Africa and the Middle East and Asia, and to see the different kinds of diseases that present in different populations, and also to see the different ways biopsies are done, different ways cancer is treated. And it's been a really eye-opening experience for me to learn from that variation. So in my practice in the United States, shave biopsy is very common. I would say the majority of the skin specimens I see are shave biopsies or sometimes punch biopsy for inflammatory skin disease, rashes. And in fact, the difference in the United States is who is doing the biopsy. If it's a dermatologist, usually shave biopsy is used. For a general surgeon or maybe a family medicine doctor, primary care, they will often do an ellipse, an excision, because of the differences in training. Shaves are often taught to dermatologists, and excisions are what surgeons do, right? They do excisions. And I know that many times my surgery colleagues have said, oh, shave biopsy, no. But even as a very paranoid dermatopathologist, if I have to have a lesion biopsied, I'm okay with the shave biopsy as long as it's done by someone with good training and they get deep enough under the lesion. The problem is sometimes shave biopsies are very superficial and very small. And then in those cases, we're often unable to give a precise diagnosis. That is the trade-off. Small biopsy is a smaller scar, but a lower chance of getting a precise diagnosis. So sometimes when I have a small biopsy of an area like this, I would say invasive carcinoma. It could be basal cell, it could be squamous, I'm not sure. Do an excision and then we will see. But if I said carcinoma here, I would be wrong. This is actually a benign lesion. And the key is not in this area, but in looking at the periphery. The tumor looks very different. It is blue and basaloid. It has some pale, almost clear cytoplasm to the cells. In English, at least, and in America, we say clear cell for things that look very different. Clear cell means sometimes totally clear white. Sometimes it just means a little bit pale, like gray or a pale eosinophilic. So we use clear to mean a lot of different things. So these cells are maybe not perfectly clear, but they're very pale. And look at the peripheral border, a nice layer of basal palisading, very similar to what you would see in basal cell carcinoma. But look at the stroma. There is not a split, a cleft. Many times basal cell will have that splitting or clefting between the tumor cells and the stroma, and there will be blue myxoid material or mucin. In the United States, there is a difference between, in pathology, pathologists say myxoid for the blue hyaluronic acid. But many dermatology-trained dermpaths will say mucin for the same thing, whereas pathologists often use mucin only for, epithelial secreted sialylated mucins. So sometimes I will say mucin, and when I mean myxoid, I use those terms kind of interchangeably because I teach both dermatologists and pathologists. So forgive me if I speak wrongly. But the lack of clefting here is helpful. The nests push down from the epidermis and have a very smooth border. So the base of the lesion is very smooth overall. A couple small nests down there, but very smooth. So at the periphery, we can see this is not an infiltrative tumor. It's a very smooth tumor that bulges down or pushes down from the epidermis into the dermis. It only looks infiltrative in the middle of the lesion, and that is very characteristic of this tumor. So this is a desmoplastic trichoepithelioma, whichever name you like. So there's nothing special about this tumor. You can just diagnose this as trichoepithelioma, period, if you like. The desmoplastic is just a pattern for pathologists to recognize so that you don't mistakenly confuse this with carcinoma. This is a good disease to know about because it may spare someone a larger surgery they don't need. These often occur on the nose or the cheek, on the face, so they may result in Mohs surgery or a larger excision and a scar if they were misdiagnosed as carcinoma. The other reason I like to talk about this tumor is the concept here. This concept is useful because multiple different skin adnexal tumors can do this. You tend to see this in trichoepithelioma very often, but you can see it also sometimes in sweat gland tumors like hidradenoma, where the middle of the lesion, if one of the cysts ruptures, it will look very busy and infiltrative. But if you see low power on a whole excision, you can tell that the periphery is very smooth. So it is kind of a pseudo infiltration, a fake infiltration. It's not really infiltrating, it just looks like it in the middle. So that's the key. And there are times if I have a biopsy, say, of like this, where I just see a tiny bit that looks a little bit like a trichoepithelioma, then I don't know for sure. I think maybe this is desmoplastic trichoepithelioma, but I'm not sure. So then in my report, I'll say basaloid neoplasm, and that this could be a trichoepithelioma, a desmoplastic trichoepithelioma, or maybe a basal or squame. I cannot see enough of the lesion, and then they can decide if they want to go and excise more or if they want to wait and watch the patient and see if the lesion recurs or not. So that's how I handle this in practice. If I see enough of this at the edge, then I feel comfortable saying this is trichoepithelioma. If it is transected broadly across the bottom of the biopsy, I usually do add a comment that I think this is benign, but if it grows back, then they should excise it or biopsy it again. So that's how I approach these in practice. It is a useful tumor to know about because trichoepithelioma are relatively common skin adnexal tumors. I see them regularly. And of course, patients with multiple trichoepithelioma may have syndromes like Cowden's, but when solitary, the majority of them that I see are incidental, sporadic tumors not associated with any syndrome. So one thing that you can do, immunohistochemistry here, I don't find very helpful, usually with one exception. Sometimes, if the features are not perfect, you can try CD34. CD34 will beautifully stain this basal layer here because this is imitating the outer root sheath of the hair follicle, okay? And the outer root sheath keratinocytes in a hair follicle often have nice, bright, membranous expression of CD34. And so sometimes that can be a helpful feature. Basal cell carcinoma usually will not have CD34 staining, whereas this tumor will. But it only works on the outside. The middle of the tumor, I find, does not often stain very well with CD34. I only do this occasionally, not usually. So that is something that can be helpful in some cases. What else was I going to tell you about? Okay. So that is a desmoplastic trichoepithelioma. A couple more things. Number one, these often have a surface that looks like verruca, a wart. This one does not, but this is so perfect otherwise that I chose this case. But many times the surface has papillomatosis, hypergranulosis, parakeratosis, all of the features that you see in verruca. And because of that, some people think that trichoepitheliomas are actually a type of HPV, human papillomavirus verruca, that's involving a hair follicle. Other people think that they are actually hair follicle tumors. It doesn't matter, right? It's benign either way. So the thing is to recognize it is the most important practically. So there have been papers that have said, oh yes, there's HPV in these, and other papers that say, no, there's no HPV. So I don't know what's really true. There are some pathologists that do not call them trichoepithelioma, but call them trichoepithelial verruca. And to me, my understanding is that means the same thing as trichoepithelioma. So that is always the case in dermatopathology. We can never have just one name. We always must have un, deux, trois, quatre, cinq, many names for each tumor. Are there any questions about trichoepithelioma?
Cowden disease or?
I do not routinely write a comment about Cowden disease, and I don't know if that's right or wrong. Some things like sebaceous tumors, I usually include a comment about Muratore, for example. But for Cowden, I feel like if it's just a single lesion, I don't routinely, but maybe I should. Or maybe I would handle it differently if it was a non-dermatologist, like a family practice doctor. Sometimes I will actually include, I use a different type of comment or language in my report, depending on who did the biopsy. A dermatologist I know is familiar with Cowden's disease and other types of syndromes, and so I don't always tell them as many things. When I'm signing out a case for a general surgeon or a family medicine doctor who may not be as familiar with uncommon skin adnexal tumors, I will often add a comment. This is a benign sweat gland tumor or hair follicle tumor. No further treatment is needed to help them not feel worried about, what do I do now? I need to go and Google and find out what this rare tumor is, right? So sometimes I change. What do you do, Arno?
I only make comments for the BAP1 tumors.
For BAP, okay.
So I'm reading the questions from the live chat. So is there anybody that can help? You've talked about CD34. Are there any other antibodies, P10 antibody?
There are other antibodies people have talked about. With many adnexal tumors, people have tried lots of antibodies. I tend to feel that most of the time in skin adnexal tumors, the H&E morphology and a large enough sample is the critical piece of information. I only use antibodies occasionally. So there are papers about different antibodies, but my personal experience is pretty limited because usually I make the diagnosis predominantly on hematoxylin and eosin morphology.
So people ask about BER-EP4.
Okay, so BER-EP4 or BER-EP4, my understanding is it should usually stain these tumors, and it will stain most hair follicle tumors, just like it will stain basal cell carcinoma. Now, there have been some papers talking about differences in pattern of staining, whether it enhances the periphery of the tumor nest or more in the center. But personally, I find those types of very subtle patterns of staining to be challenging and difficult to practically use in my practice because I can make the stain say whatever I clicked.
No,
Oh, it's good. I can make the stain say what I want it to say, right? If I want, I can say, oh, yeah, it's kind of a little bit strong on the outside. I think it's this. Or, oh, it's more diffuse. So I find in the end, it's just about as good to me as flipping a coin. So it's kind of like HMB45 for maturation in melanocytic lesions. Forgive me, Arnaud. It's very nervous to speak when there's a world expert in the audience. But I feel like it works beautifully on congenital nevi, where you don't need it at all. But on difficult, problematic lesions, it's more subtle and vague. And then I can say, if I want it to be benign, oh yes, good maturation. If I want it to be malignant, I'll say, there's a little staining down deep. I'm concerned. So I'm not saying that to be too flippant. But I mean, I do think that practically the immunostains I find most useful are very binary, right? Strong diffuse, or anything less than that is negative. Strong diffuse is positive. So my favorite immunostains are stains like that. Unfortunately, many immunostains are not that way, right? So I don't know, the struggle is real, as we say in English. It's a struggle every day. No matter how long you do this, it's still hard. I keep telling my fellows and residents, I thought one day dermatopathology would get easy, but that day has not happened yet, so, oh well. Is it good?
Yes.
Anything else? Okay.
When I tell you the question, can you repeat the question?
Oh, yes, thank you very much. For the previous two questions, the first one was, are there any antibodies that can help with the differential diagnosis of desmoplastic trichoepithelioma versus a basal cell carcinoma or squamous cell carcinoma? And the second question was, what is the utility of BER-EP4 or BER-EP4 in this differential? And then Dr. de la Fouchaudière, forgive me for the pronunciation, asked the question about whether or not I include a comment about Cowden's disease whenever I routinely sign these out. And the answer for me is that I do not, but I think that there could be multiple different ways to handle that. Okay. So case 2. This is a 35-year-old woman with a firm papule on the cheek. Mm-hmm. It's no problem. This is all good. Je suis à Paris, so c'est bon. I'm super happy. So this is case 2, a 35-year-old woman with a firm papule on the cheek and a shaved biopsy, see? Now this is a good shaved biopsy, nice and deep. Sometimes not so much. It will be like this or maybe like this, and then it's more difficult, right? And I like to always, when I'm working with my residents and fellows, but even myself, I think, would I have made the diagnosis if the shave biopsy went to here or here? And even on excisions, I try to think, what would I have called this if I only had a superficial shave? It's a very scary game to play, but it's good to practice thinking about how to approach small biopsies of larger lesions. So here we have 3 pieces of tissue. And from low power, the first thing that I notice is these large keratin-filled milia or microcysts filled with keratin. And the second thing is you can see that there's a little bit of normal dermis out here, but the dermis here is very bright pink, dense, increased sclerotic collagen, and there are small islands, cords, nests, strands, whatever words you like, of something infiltrating, trickling in between this dense collagen. So that's what I see at low power. Let's go closer. The keratin cysts look like any other benign keratin cyst. The epidermoid cyst or milium or dilated hair follicle is all the same. They're lined by multiple layers of benign keratinocytes with a bit of granular layer and loose keratin contents. And like any keratin-based cyst, they have a tendency to rupture sometimes. And when they do, they create a foreign body keratin giant cell reaction or keratin granuloma, very common. Sometimes the granulomas can become calcified. I can't remember, yes, there, right there, see? Calcium is very common to see alongside these ruptured small cysts. Okay, so let's look at the center of the lesion. So we see islands, elongated kind of cords and strands of basaloid cells. And they, again, have a very infiltrative appearance, right? Because they are intercalating or trickling, whatever word you like, between the background collagen. And the collagen behind them is very dense, more dense than normal dermal collagen. The collagen density of the dermis is a subtle clue, but I think it can be helpful in some lesions. So it's worth studying normal skin to see what the texture and density of the normal papillary dermis looks like and the normal reticular dermis, because sometimes subtle changes in that collagen pattern or density or texture can be very important clues for different diagnoses. All right? The cells are very bland. They all look perfectly identical, small, round cells, very bland, no pleomorphism, very little, if any, mitotic activity. The stroma is dense collagen with no blue myxoid color, no clefting or splitting, all right? And some people would say that the shape of these nests kind of look like a tadpole, right? I don't know, comment tu dis en français? Tadpole, the little baby frogs. Tita? Oh, tita, that's so cute. Yes. Très belle. Tita, okay. So tadpole in English. And, or the ties that people wore long ago, paisley. How do you use it? Cravata. Ah, yes. So the paisley tie pattern is what we often say in English, where you have a larger area and then a small tail coming off behind. So there is a classic differential diagnosis for this pattern in dermatopathology. And the 4 main entities that we talk about are syringoma, basal cell carcinoma, morphiiform basal cell carcinoma, or I usually just call them infiltrative basal cell carcinoma to encompass morphiiform and micronodular. That's the way I do in my practice, but the other 2 things are desmoplastic trichoepithelioma and also microcystic adnexal carcinoma, or MAC is the other short name that we use as an acronym in English. Do you use acronyms in pathology in France? Like where you use the first letter from each word? It's very common in English, but I know people my colleagues in Spanish-speaking countries are like, they don't do that as often, so maybe it is just an American thing. Okay. So the differential of those, I think syringoma is usually the easiest to exclude because syringoma has obvious sweat duct formation. You can usually see easily sweat ducts in each of the islands here, and they are multiple, not just rare. So here, these don't have any ducts that I can see, right? They're solid strands. The only openings or spaces are these. But this is just keratin material. These are not sweat gland secretion in a duct. Sometimes it is difficult to be sure if you're dealing with a duct with some sweat secretion, or if you're dealing with a little cyst with keratin debris. I think it can be challenging in some cases to tell that apart. But I think these are all little tiny keratin cysts with swirls of keratin, similar to this, analogous to that. Okay. So syringoma, I think, is excluded. There's no ducts. Basal cell carcinoma can have infiltrative cords, but usually, if you have a large enough biopsy, you will see obvious areas of classic basal cell carcinoma somewhere on the biopsy. Not always, but most cases will have some areas with larger nests connecting to the epidermis, basal palisading, clefting artifacts, myxoid stroma change. I have seen a small number that did not have those features, but most of the time you can see those findings. So what I think we usually end up being left with is desmoplastic trichoepithelioma versus microcystic adnexal carcinoma. And that is very challenging and difficult to distinguish, I feel, especially on a shave biopsy. The important feature to see is duct formation, to see sweat ducts, because microcystic adnexal carcinoma is a sweat gland or sweat duct neoplasm, and desmoplastic trichoepithelioma is a hair follicle tumor. But the problem is that the ducts in microcystic adnexal carcinoma are often very small and subtle, and often they are best seen deep down in the lesion, at the very deep dermis or even the subcutis. So on a shave biopsy, you often cannot see them well. The other problem that arises is that sometimes, let me see. Sometimes you will find a duct, a sweat duct, but you're not sure, does the sweat duct belong to the tumor, or is it just a background sweat duct that happened to be trapped in the middle? And I think this is true of all of the tumors where we're thinking of sweat gland differentiation or sweat duct. It can be challenging to know if one duct is just entrapped or if it's truly part of the neoplasm. I can't remember if this case had, down. Yes. So you can wonder, are you seeing an entrapped duct or not? So that's another difficulty that I encounter. So you can try some immunostains here. Carcinoembryonic antigen, CEA. I find one of the more useful stains to highlight sweat ducts. The apical lumen lining of the duct will stain strongly, but is not a perfect stain. For one thing, when the ducts are very compressed, it can be challenging to interpret. The clone of CEA that we use in Okay, carcinoembryonic antigen, we'll just stick with that, in our laboratory, it will stain neutrophils a lot of times. I think that must be a clone specific, and I don't remember what clone we use. But the other thing too is that sometimes keratin debris can non-specifically stain with carcinoembryonic antigen. So it's not perfect. I find it most helpful if I'm looking at a tumor that I think is either maybe poroma versus seborrheic keratosis, and I see cystic spaces, or squamous cell carcinoma in situ versus porocarcinoma. I see spaces that look like a duct, and I do carcinoembryonic antigen, and they're totally negative. Well, probably it's just a artifactual space, not a true sweat duct. When I can't see ducts on H&E, I find that carcinoembryonic antigen is not terribly helpful. And you can try epithelial membrane antigen, but it stains a lot of things. I don't find it as useful. One stain that I do like here is cytokeratin 20, CK20. Cytokeratin 20 in desmoplastic trichoepithelioma and in many hair follicle tumors will highlight benign Merkel cells scattered in the midst as kind of colonizing the tumor. And you don't usually see those cells, or very few of them, in microcystic adnexal carcinoma or basal cell carcinoma. So of the stains that I've used over time, that one I personally find the most useful. Even still, on a biopsy like this, I would feel very comfortable saying desmoplastic trichoepithelioma based on the morphology. And if I had cytokeratin 20 cells, that would be great. I think this case was one from a teaching collection, so I don't know if CK20 was performed here or not. But I think this looks very classic to me for desmoplastic trichoepithelioma. But on a very small biopsy, I find that even with the immunostains, in the end, I still add a comment saying, well, I'm not totally sure, and I'd like to see how deep the tumor goes. Desmoplastic trichoepithelioma is usually confined to the dermis and has maybe minimal or no involvement of the subcutis. If you see extensive infiltrative growth deep down, that is very worrisome that you're probably dealing with microcystic adnexal carcinoma or some other type of adnexal carcinoma. Now, one thing I mentioned in the handout, but let me see, I think I have it. But is the idea of perineural involvement, okay? I was trained that if the tumor infiltrates around a nerve, then it is malignant and it is microcystic adnexal carcinoma. But over time, there have been papers published saying that you can actually see nerve involvement in benign desmoplastic trichoepithelioma, and that with follow-up, those patients have a good outcome. When I first heard that, I did not believe. I thought, no, it doesn't make sense. Sometimes science challenges our preconceived ideas. But the paper was published by a very good group, the group at Yale University, Dr. Jennifer McNiff's group, and they published excellent material. And when I actually took the time and read the paper, I thought it was a very convincing argument. And in practice, I've now seen a couple of cases that I call desmoplastic trichoepithelioma that did have small dermal nerve involvement. And to my knowledge, no bad outcome happened from those cases. So it makes you feel uncomfortable to see that, but it made me feel better once I realized that the literature describes this and says actually it's not rare, but a relatively common finding in this tumor. Now I see Dermpath cases, many cases every day, but I only encounter desmoplastic trichoepithelioma maybe, I don't know, 3 or 4 times a year maximum. So these are rare tumors. So I don't see them very often. And if there's any doubt, I usually do say I would like them to either do either 2 options. They can do a deep punch down to the level of fat or a small ellipse. Because remember, these do often occur on the face in young adults. So there is a cosmetic implication here that you may be leaving an unnecessary excision, may leave a large or a noticeable scar on the face of a young adult who otherwise may not have facial blemishes. Maybe that's not as serious as some of the side effects of the treatments that we have for patients, but it's something worth thinking about, I believe. We always have to make sure that we are taking patient well-being and avoiding problems for the patient, and that's harmful, but also I think cosmetic results are something we should take into account and think about. All right, so let me see if I have it here. I think I have another example. These are my unposted cases. So you're seeing the secret, I can't spell. Because that's not it. This French keyboard is very challenging for me. So you're seeing the secret unposted cases that I've got. I've got a bunch of them. I think it was. And see, this is a nice excision, right? And you can see the lesion stops right there at the dermal subcutaneous junction. Look at the calcifications. Look at the cysts, cords, dense collagen, all the stuff I just showed you. but you can have small nerve involvement where the tumor sits right next to the nerve. So I don't call that perineural invasion. I just say it's, it's perineural growth of the tumor, all right? We use different words depending on if we want something to be cancer or benign, right? It's true. All right. Well, I'll have to take a picture and post it later on Twitter. All right. So any questions here? Very challenging diagnosis. So this is case 3, a 60-year-old woman with a firm scar-like plaque on the cheek. So a little bit older in this case, but the same kind of differential. And usually, if someone does an excision of this size on the face, that means at one point someone called this cancer, right? So you can kind of cheat a little bit when you're looking at unknown cases, and you know if it's a face or scalp site and someone has excised it down to the level of, the fascia or way down deep, then probably it has been called cancer, at least at one point. This is a terrifying case because if you had a shaved biopsy, there's a few strands and you'd say, well, I don't know, what is that? Maybe reactive sweat duct or actinic keratosis, I don't know. I would not know that what this diagnosis is just on this. I would wonder what those little islands meant, and I might be descriptive. I don't know what I would do if I had a shave of that. I'd probably want a clinical photograph. And we are very lucky in my practice. I have clinical photographs for the majority of dermatopathology cases I see. That is a very rare and wonderful thing. Many dermatopathologists do not get clinical photographs, but we have a very closely working team between our dermatology department and our dermatopathologists, and so they routinely take photographs of almost everything that they biopsy, which is just amazing. It makes a huge difference sometimes in patient care. There are times where I'll have a report written, ready to go, and then I look at the clinical photo, delete. Just delete the whole thing because there's no way it can be right based on the clinical. It looked right microscopically, but no way does it make sense clinically. So working with your dermatologists or family doctors or surgeons and encouraging them and convincing them that photographs are not just for educational interest, although they often serve that purpose, but that sometimes they can really make a crucial difference in patient care and in outcomes for their patient, and also to avoid legal problems and other issues for us on top of taking better care of the patient. So I think that it's worth having those conversations because it's not hard to take a photograph. It does take a little bit of time. I think the bigger problem is that sometimes there's some paperwork or permissions that need to be done. But once that's included in the normal workflow of bringing a patient into clinic, that's not a problem. You just include that in the basic paperwork. And it's also a part of changing the culture of the way a clinic runs and convincing your colleagues. So my dermatologists do this, but I'm a little bit off topic, but my gynecologists, when they do vulvar biopsies, I rarely see photographs. So my fellows are actually currently working on a project to try to convince our gynecologic, obstetric and gynecology colleagues that it's worth taking photographs because sometimes it makes a huge difference in our ability to properly diagnose a case. So if you find that frustrating in your practice, try to talk to your colleagues and help convince them over time. Sometimes you have to talk about it multiple times over years to make progress, but it's worth it for the patients, okay? So here, the issue is down deep. It's very difficult at the top of the lesion to see what's going on. There are only a very small number of keratin cysts, like we saw in desmoplastic trichoepithelioma. Deeper down, there are infiltrative cords and strands and nests of tumor cells with dense sclerotic collagen. But the difference here is we have ducts. Nice, obvious, clear, punched out, sharply circumscribed sweat duct lumens. A couple clues to identifying ducts. Number one, sometimes they contain dried sweat secretion, pink, dense material. That can be difficult to tell apart from keratin, but I find that it's more globular and it's not as loose and flaky as keratin usually. The other thing, and this, I apologize, this scan I think is not at 40x, but there is a very small, dense layer of pink material that lines the inner surface of the sweat duct, and that's called a cuticle. And the presence of that dense pink material lining the duct is very helpful to identify something as a true sweat duct rather than an artifactual space or vacuole. So I find that very helpful. But you can see here we have a duct, sharp circumscription, dense pink lining, small bit of secretion. That's a duct, 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 duct. Okay. So that is helpful here. The one thing I do want you to notice is what we don't have is we don't have cytologic atypia, right? Those look like benign cells to me cytologically. Now, I'm not a cytopathologist, but I mean, that looks like the same kind of cytology that I'd see in a normal eccrine sweat duct. But the problem is that there are way too many ducts here to be normal, and look how deep they go. They keep going, and uh-oh, we're in skeletal muscle, and there's still ducts everywhere. On and on and on. And that is the classic finding that you see in microcystic adnexal carcinoma. The deep infiltration of sweat ducts invading deeply into the fat, even into the skeletal muscle. Now, you do have to be careful because remember, on the face, sometimes skeletal muscle is in the dermis, right? The muscles of facial expression have little bundles that stretch up into the dermis. So the involvement of skeletal muscle in the face is not always diagnostic of cancer, okay? Sometimes things can involve dermal skeletal muscle, and if it's in the dermis, that to me usually doesn't mean anything. That's coincidence, okay? It's when we're down deep below the fat and well into the muscle, then that's a significant problem. And the other thing that this case has, I mean, this is real, not just perineural, but intraneural. Look at that. They look like benign sweat ducts, but they are in the middle of a large, relatively large, deeper nerve, multiple ducts everywhere. So this is, I think, the most classic and characteristic example that I've seen so far of microcystic adnexal carcinoma. I only see these maybe every few years, and it's rare for me to get a nice big excision specimen. And most often it's small biopsy and lots of difficulties. I have seen one case that we believe, or we decided was microcystic adnexal carcinoma that did not invade beyond the dermis, but it was very wide and broad. And it was a Mohs surgery, I think it was an ear if I recall. And they did layer, and it was positive. Another layer, positive. I think they did 5 layers, and it was still there. And we did cytokeratin 20, and there were almost no Merkel cells. And we decided this must be microcystic adnexal, even though it wasn't invading deeply. But most of the cases will invade deeply into the adipose tissue or beyond. These tumors are malignant by nature of their infiltrative growth. They supposedly do not have a high tendency for metastasis. I personally have seen so few cases that I don't have a good personal experience with the outcomes, but they do have a tendency to recur locally, and they do present usually on the face of young or middle-aged adults, and so they can be quite problematic because of their aggressive local growth, right? So kind of I think sometimes adnexal tumors are analogous to salivary gland tumors. Sometimes malignancy is because of atypia, mitoses, necrosis, the cytologic malignant features, but other times it's because of the growth pattern, that infiltrative or destructive growth. So there are 2 different ways that you kind of can get to malignancy, I think, in adnexal tumors. So that's kind of the way I think about it. So that is microcystic adnexal carcinoma. And let me show you, I forgot on the last case. This is what you would see in a benign hair follicle tumor, like a desmoplastic trichoepithelioma. This particular case was, if I recall, a trichofolliculoma, and I just did the stain for educational purposes, and it worked beautifully. So if you do cytokeratin 20 on normal skin, Or the next time, maybe you're thinking, is this basal cell or Merkel cell carcinoma? And you do keratin 20, look at the epidermis and the hair follicles of the normal skin, and you will often see scattered occasional CK20 positive cells. They often have kind of a slightly branching dendritic appearance, and they're usually located along the basal layer, often within the hair follicle openings or down in the hair follicle. And those are normal benign Merkel cells, okay? I have looked, and I cannot recognize them on H&E. I've even looked in cases like this where I know there are lots, and I look closely, so I don't know what they look like on H&E. I must be seeing them, but I do not recognize them. So, but you can find them on CK20. Also, if you happen to do like a CAM 5.2 or other low molecular weight cytokeratins, sometimes you'll see random cells staining in the epidermis. That's what you're seeing, is these benign Merkel cells. So when you have many of them scattered in the middle of a basaloid neoplasm, that is a very nice supportive feature that points in favor of a benign hair follicle neoplasm, okay? So usually you will not see this in basal cell carcinoma, and you usually will not see these cells in microcystic adnexal. Or you might see one or two, but not many. In a benign hair follicle tumors, they're usually scattered throughout. Now, I have tried this once or twice for trichoepithelioma, and I did not see any. So I don't think this works. Trichoepithelioma, because it's so close to the epidermis, doesn't seem to have the cytokeratin 20. I don't know. Have you tried this on trichoepithelioma? I just tried it for education once or twice, and on things that I was certain were trichoepithelioma, and I didn't see them. So, but many other, like trichoepithelioma, desmoplastic trichoepithelioma, trichoblastomas usually, you will tend to see these scattered Merkel cells. Kind of passengers, they're just on the train for a ride, right? They're not part of the tumor, they're just hanging out with the tumor. So that's the way I think of it. That's a closer look. So those are and whenever I mention these in my microscopic description, I say cytokeratin 20 stains scattered benign Merkel cells. I make sure to include that word because Merkel cell by itself, even though it's a normal cell type, to most doctors, that means bad cancer, right? So just to make sure that there's no confusion, I say they are benign Merkel cells and they're scattered there, colonizing the tumor. This supports a benign hair follicle tumor. So I don't mind being redundant. As you can tell, I am very verbose. I use lots of words when I talk, and I use lots of words when I write. Je suis désolé. It's just the way I am. There we go. So microcystic adnexal carcinoma. Does anyone have questions about this? Case 4. A 45-year-old man with a slowly growing thumb nodule. The clinical impression was cyst. Now, I don't know about in France, but in my practice, everything comes in as rule out cyst or rule out lipoma. It's always a cyst or a lipoma until it's not a cyst or a lipoma, until it's some rare sweat gland tumor or sarcoma or any other thing. And so this is a crucial point, maybe not so much for pathologists who already get this, but for our clinical colleagues, or if you teach medical students, I always hammered on this point to my med students. Everything that is a nodule in the deep dermis or subcutis, it doesn't matter what it's made of. If it's a nodule down deep, it will look like a skin-colored lump, bump, nodule, papule that will look identical to a cyst or a lipoma because those are very common. And usually a skin-colored lump or bump is a cyst or a lipoma, statistically speaking. But every once in a while, it's something else. And I've seen many patients. I volunteer in some rare cancer patient groups on Facebook, like dermatofibrosarcoma protuberans and angiosarcoma. And some of those groups, particularly dermatofibrosarcoma protuberans, many of those patients were misdiagnosed for years as just having a cyst, don't worry about it. And then finally someone did a biopsy once it starts, fungating out of the skin. And of course it was sarcoma. So I think it's important for our colleagues to know the only way to really know something's a cyst is to biopsy or excise it and let us take a look microscopically. So that's kind of a point that I feel very deeply about. So, well, it is cystic, but it's not a regular cyst, right? It's not an epidermoid or follicular cyst or pilar cyst. It's something else. So we have a somewhat fragmented specimen. And this is often the case in lesions that are removed from the acral soft tissue or skin, from the digits, the hands, and the feet. And I think part of that is because of how close all of the tissue planes are here. Skin and fascia, tendon sheath, tendon, ligament, synovium, bone, periosteum, all present within 1 centimeter of each other in your fingers and toes. And because of that, tumors that grow in those sites are often difficult to remove in a nice, compact fashion. And I think also hand surgeons and foot surgeons, they are cautious to not damage normal structures. So I think they use more blunt dissection and pull, which is appropriate, I think. So because of that, when you see a nodule of something that has no fat around it, no skin over it, has some kind of tendon-like connective tissue, and it's kind of fragmented or ripped at the edges, usually that's a clue that you're probably dealing with something from the hands or the feet. So that can be helpful sometimes. So here we have both cystic areas and also dense hypercellular areas from low power. If we go in closer, whoa. Excuse me. All right. We can see that in some areas, the cyst is lined by papillary or micropapillary structures, little fingers of cells protruding out into the cyst lumen. Some of them, of course, like with other micropapillary things, will break off or be tangentially sectioned, so you just see little floating islands without any, in this case, without any fibrovascular core. The cells are relatively uniform and bland. I think in some areas on this particular case, there was more atypia and mitotic activity. But at first glance, even though the case is hyperchromatic, a part of that is due to the H&E on this particular case. I remember the lab that did this had a kind of darker hematoxylin and eosin stain. So that's one thing that my dermatopathology mentor, Dr. Douglas Parker from Emory, he taught me when I was a fellow that when you're looking at a difficult case from an outside laboratory, like as a consult, try to get the block and do your own H&E stain. It's not that the outside H&E is wrong or bad, but it's different than what you're used to and what your threshold is set at diagnostically. So it can be helpful to see it on your home soil, so to speak, right? In your native laboratory and looking at it under those conditions. And I have found that to be useful sometimes. So there's a little tip. So we have little papillae and micropapillae, cystic spaces. Let's go look at the cellular component. Oh, it's upside down now, I realize. So the cellular area is kind of looks like a cyst, but filled in with sheets of these cells. In some areas, the sheets are totally solid, round, or oval nuclei. Here you start to see some mitotic activity, but relatively uniform nuclear size and shape. But in other areas, we see this, and this I think is very helpful. We see ducts or tubules, right? Lumens. Nice duct lumens. And here we don't really see the cuticle so much like we saw in those sweat ducts in the microcystic adnexal carcinoma, but we see that the lining see how it has its own lining. There's the basal layer out here. And look at this kind of columnar lining that lines each of the tubule spaces. I find that pretty characteristic in this entity. See right here? See how that duct right there, it has its own little lining of cells that all are oriented towards the duct lumen. And those tubules are punctuated, kind of scattered in the midst of this solid sheet of cells. So this combination of features, solid sheets with tubules, cystic spaces, and papillary structures of varying size and shape on an acral surface is the characteristic findings of digital papillary adenocarcinoma. It used to be called aggressive digital papillary adenocarcinoma, but over time they've dropped the aggressive part of the name because it is a malignancy, but it's not that much more aggressive than a lot of other adenocarcinomas. So the current tendency is to just call these digital papillary adenocarcinoma. These are relatively rare, but they are not well recognized by many pathologists. So it is a dangerous pitfall. This one did have some areas with atypia, but much of the tumor was relatively bland cytologically. And I feel like I've seen quite a few of these now. The majority that I have seen did not look cytologically malignant. They looked cytologically benign, but they're malignant by nature of having the papillary structures and the cystic spaces and being usually in the digits, like the thumb is a good site, but the digits, hands, or sometimes feet, usually in a middle-aged adult, and they're more common in men, although they can occur in women as well. So those findings together are what are diagnostic of this tumor. So they're important to know that anytime I see what I think is a sweat gland tumor with any cystic change, or even without cystic change, and I'm in the digits, I always stop and think, could this be digital papillary adenocarcinoma? There are some times where they don't have well-formed papillae. There are some cases that are totally solid and don't have cystic spaces. And the other difficulty is that sometimes hydradenomas, which are benign and can arise in the hands and feet, can have areas that look similar to this. And I have struggled with that before. And the difference is pretty big because I can't remember, it's 20 or 25% of these will eventually metastasize either to the regional lymph nodes or to the lungs. So these are tumors that can be very bland and deceptively benign and yet have the potential for fatal outcome to the patient. And when they're treated, they sometimes will have a tendency to recur, which may result in an amputation of a digit or a ray amputation involving part of the hand. So you don't want to be wrong. You don't want to miss this, but you don't want to overdiagnose it because it may result in overly aggressive treatments, okay? And I think it's a rare tumor, but it is out there and it's good to know about. So I just make a rule for myself. Anything that I think looks like sweat gland tumor, making a nodule in the hands and feet, I always stop and think, maybe could it be that? And then try to prove that it's something else to make sure that I don't miss this rare pitfall. It's a good thing to do for rare pitfalls because they're things that are not on the top of our mind. So when there's something we know is a rare thing but a very dangerous mimic, I just if I think it looks like a rheumatoid nodule, I always ask myself, could it be epithelioid sarcoma? Because they're rare, but they're bad. And I know that they can mimic rheumatoid nodules, so I ask myself as a habit every time in my head, could it be? No, it's fine. And then I move to the next case. But if you don't teach yourself to ask those questions, there's the potential that you will go past it and not think of it because it's an uncommon thing. Okay, so this is a very good example, very classic example. And I think most of them that I've seen are nodules like this down in the deep dermis or subcutaneous or even at the tendon sheath level, but I have rarely seen them present in the dermis actually and have an infiltrative growth pattern, but I think that's much less common. Usually they look like this. They may have infiltration at the edge or they may be very well circumscribed, and just remember that they are not always malignant in appearance. I personally don't find immunohistochemistry to be terribly helpful here in discriminating it, but some people do occasionally use immunostains in this context. I don't have a great familiarity with which stains people like, but I think I've also noticed, oh yeah, that's what I meant to tell you. Not always, but some cases have this kind of squamoid whorled, almost like the morules, that you see in endometrial carcinomas, right? Sometimes get those whorled squamoid areas. Sometimes you can see that in this tumor. I think that's a very useful clue, but is not always present. So these are important tumors to know about and rare, but potentially a very big problem for the patient. So that is digital papillary adenocarcinoma. Any questions about that?
The treatment is
Yes, it is. And I think that there's been some literature that talks about amputation. So some surgeons seem to want to go straight to amputation. It's my personal view, having worked with a handful of different doctors who have treated these, I think it's reasonable to try to excise with negative margins and spare the digit and follow the patient. They're so rare, I don't know if there's a good prospective study comparing that versus amputation. So I think that's the problem with rare tumors like this. We don't always know what to do. Different people do different things, but there's not good evidence or proof in a large sample size because they're so rare. Well, the question is the papillary component the distinguishing feature to exclude a cystic hydradenoма? I think in general, yes, that's the most helpful feature because hydradenomas don't usually have these kinds of structures, like real nice micropapillary structures, but sometimes they can have areas that protrude into the cystic space and look papillary. And in the past, they tried for a while, long ago, to sort out digital papillary adenomas from adenocarcinomas, to say if they look malignant, we'll call them adenocarcinoma. If they're cytologically benign, we'll call them adenoma. And then it turned out that pretty much all of the papillary appearing tumors like this, regardless of cytologic atypia, had a potential for metastasis, which is why they're now lumped all together under adenocarcinoma. But I have to admit, I still find it a real struggle sometimes to tell these apart from hydradenoma. And I had a case not that long ago in the past where I thought it was a papillary adenocarcinoma. And I had colleagues who thought that too, but we sent it for an expert consultation, and the expert said that they thought it was a hydradenoma. I don't know for sure what the outcome was in that case, but I still feel worried about that and told the surgeon that I want them to closely follow that patient and ideally try to get a negative margin if they can, because I feel very worried about anything that has any papillary appearance when it's in the digits, because I'm afraid of missing one of these. Any other questions or comments? That's good. Thank you for that. The point was made by Dr. Corina Socha,
yeah.
Right? That there have been papers that describe that resection with clean margins versus amputation, the metastatic risks seem to be the same, and it was around 20%. So I wonder if that was the MD Anderson group paper. They published a large series on this, but there have been others, and I've not read all of the papers on this. So, but I think that's good to know, and that's been my approach. And I also think a good thing in any of the malignant sweat gland tumors, particularly in the hands and feet, but even in the extremities, I often recommend to my dermatology colleagues that they get either hands surgery or just orthopedic oncology involved. So orthopedic oncology is the term in the United States that we use for orthopedic surgeons who specialize in bone and soft tissue malignancies like sarcoma. So even though these tumors are not sarcomas, there are a lot of similar features in regards to surgical management, right? To remove a tumor with a negative margin on the extremity without compromising the neurovascular structures. And sarcoma surgeons are experts at doing that. They remove large malignancies from the extremities every day. So I have found, and in my practice, I've actually recommended a lot of times to consult with sarcoma surgeons when dealing with a malignant adnexal tumor on the extremity, or even really bad large squamous cell carcinomas, because I feel like they're very familiar with how to do that surgical approach, even though biologically these are different tumors. So usually when one of my sarcoma surgery colleagues is seeing a squamous cell carcinoma, that means it's really bad. So, but I found that they often have a lot of value to add, and the same for hand and foot surgeons. So I think it's good to have that team-based approach and to discuss these patients at multidisciplinary tumor board and to bring different viewpoints into the discussion in crafting the best approach for patient care. And I feel that's obviously, I'm sure that you do many multidisciplinary tumor boards here. I found that to be a wonderful way, especially for rare diseases, to come up with the best strategic approach for managing the patients. I learn a lot from attending those conferences, and occasionally I'm able to bring up literature or input from my experience that comes into the discussion, and I love getting to participate in patient care in that way. Okay, let's do case number 5. This is a 75-year-old woman with a nodule on the lower eyelid. And there are pictures of all these in the very nice book that Agnés put together and translated. So you can see all of those. So 75-year-old woman with nodule on the lower eyelid, excuse me. And do I have... Oh, okay, good. So here you can see a cystic lesion, and it connects focally to the surface of the skin. There's a lot of debris and secretion material trapped in the lumen with blood. And then there's a little focus down here of cells that are outside the cyst in the dermis. So let's look first at the cyst. There, that's better. The epidermis has to be at the top, right? Okay. So if you just had the cyst here, I mean, this could be if you didn't have this little island, this could be the top of an epidermoid cyst or follicular and fundibular cyst. But as you go down here, you begin to see the lining changes. And what you have is a kind of double layer cuboidal to columnar lining with a small little luminal projections or apocrine snouts that stick into the lumen. It's a little hard to see here. You could even wonder if there's cilia at first glance, but I think they're little snouts that protrude into the lumen. So this area here, to my eye, looks identical to a hydrocystoma, which is a benign cystic lesion from sweat gland or duct origin that usually arises on the upper cheek or the eyelids, often in adult women, and they're often multiple. But as we go down further here, you can see, look, there's a little duct here that kind of looks similar, but starts to have some tiny papillary structures. And there's more papillary structures here. And then down towards the bottom, the papillary structures become more pronounced, and they protrude into the lumen of the cystic space. I guess it's okay. All right. The nuclei are round and uniform and a bit hyperchromatic. On this scan, it's a bit difficult to see the chromatin pattern, but they don't look cytologically malignant to my eye at first glance, at least. So a lot of times if I see this appearance of a solid or papillary areas protruding into a hydrocystoma, I would call this a cyst adenoma, okay? But in more recent years, in the past 10 years or so, there is a newer entity that's been described. And now, anytime I think I see a cyst adenoma, if it looks like a hydrocystoma but has any cellularity or papillary growth, particularly if there's some blue mucin with it, I wonder about the possibility of endocrine mucin-producing sweat gland carcinoma. And I'm starting to wonder if maybe all of the things, or almost all of the things that look like cystadenoma are maybe actually this. So these have been described, and Artur Zembowitz from the United States, from Massachusetts, is one of the people who first described and has written the most probably about this entity. If you do neuroendocrine markers, they will be positive for synaptophysin or, to a lesser extent, chromogranin. And I've found more recently, if you have it in your lab, INSM1, insulinoma-like protein. And that works quite nicely as a nice nuclear stain that stains many different endocrine tumors, Merkel cell carcinoma, this tumor, and others. So these are, although they are called carcinoma, they are indolent and have a good prognosis. They do need to be excised. But what we understand now is that these probably serve as a form of precursor lesion to invasive mucinous carcinoma, which also usually arises near the eyelids or adjacent areas in adults. So whenever I see this, we go and look and see, are there any areas of invasive mucinous carcinoma? And in this case, there is. Right here. There we have islands of bland, relatively uniform, round cells that are arranged into nests or islands that are floating in a background, pools of loose blue mucin in the middle of the dermis. So you've all probably seen mucinous carcinomas, either of the skin or the breast or other parts of the body before. But in the skin, they have a very similar appearance to when they occur elsewhere. They can have atypia sometimes, but most of the ones I've seen were relatively bland and uniform cytology rather than pleomorphism. But they can have a range of different features. So mucinous carcinomas seem to arise from this precursor. When you look at mucinous carcinomas, some of them seem to arise out of cystic areas or solid areas that are within a dilated sweat duct space. And one of the papers that talked about that they're kind of analogous, the background precursor areas are analogous morphologically to what you see in the breast. Usual ductal hyperplasia, atypical ductal hyperplasia, and ductal carcinoma in situ. So they made that connection way back that there were areas that looked kind of similar to breast, those different breast lesions, and then a lot of times they would see an invasive mucinous carcinoma component growing adjacent to that kind of precursor lesion that's developing within a sweat duct. I think probably those lesions all represent the same thing as this endocrine mucin-producing sweat gland carcinoma, now that we've made the connection that these usually have a neuroendocrine immunophenotype. So the reason that this is important is, number one, if you just see this lesion by itself without invasive mucinous carcinoma, it still probably should be completely excised and the patient should be followed. The outcomes, as far as I understand, are very good, but they probably should be completely treated. Okay? The other reason is that when you have a mucinous carcinoma, an invasive mucinous carcinoma in the dermis, there's always the question of, is this primary from the skin or is this a metastasis? And whenever you raise that question, that creates a great deal of difficulty for the treating physician and the patient. Because what do? You full body scan, head to toe, a breast exam. I mean, like, how far do you pursue that? It's actually is a simple thing to write in your report, rule out metastasis, but actually creates a lot of difficulty and expense in working up the patient. So in my experience so far, whenever I've seen mucinous carcinoma in skin, has almost always been primary, especially if it's near the eyes. I have never personally seen a metastatic carcinoma from the breast or any internal site near the eye. Is it possible? Sure. Anything's possible, right? If you have to ask, can it happen? Yes, it can happen. It will eventually. Give it enough time, and Arnaud or someone else will publish 2 examples of metastatic something that should never be able to happen, but yet it does. So anytime I say in a lecture, you never see this, it'll come out next year. Someone will publish a case of it. So this is the joy and the pain of pathology, right? Nothing is ever certain, but we always get to learn new things. So, all right. But in any case, I feel like from a statistical standpoint, unless the patient has a known history, very unlikely that a mucinous carcinoma around the eye is a metastasis, but it is theoretically possible. Thank you. The reason that knowing about the endocrine mucin-producing sweat gland carcinoma, this basically in situ precursor, is when you have this and mucinous carcinoma is growing out of this, you can be essentially certain that what you're dealing with is a primary skin tumor and not a metastasis. So looking for this background entity is more than just an academic exercise. It actually can give you a definitive answer, or as close to definitive as we can get, maybe, that what you're seeing is arising in the skin as a primary skin tumor, and metastasis is not a question. So I think I have seen like one mucinous carcinoma of the colon that metastasized like to the thigh or somewhere. I've seen it once, a metastasis, but again, never near the eye. So, but when you find this, you know that you're dealing with a primary skin tumor. So the way that you can tell is when you look closely at the lining, you have the apical cells, just like you have in a hydrocystoma, the apical cells and all of the complex infolding here and growth, but there's a layer of basal cells, kind of analogous to the myoepithelial cells of the breast, right? These are kind of the basal cell layer that you see in normal sweat ducts. And you can highlight these with immunohistochemistry using basal cell type markers. So here's an example. This is an immunostain for P63. And you could use P40, which is essentially is an analog of P63, as I'm sure you all know. And in my hands, P63 and P40 work almost the same with occasional exceptions. I like P40 a little bit better. I feel like it's a little cleaner and more crisp. And there are a few things that it will do better, like metastatic lung adenocarcinoma. That sometimes goes to the skin. And lung adenos can stain with P63, but usually not with P40. So if you have P40, use that. But if you only have P63, that's okay. This is P63. So just as a reminder, P63 stains the nuclei of most of the normal epithelial structures of the skin. That includes the epidermis, the hair follicle epithelium, and many components of the sweat ducts and sweat glands, okay? So the reason that's important to know is that in the skin, if you have a tumor that is derived from the epidermis or from the adnexa, either benign or malignant, usually it will have diffuse, strong nuclear staining with P63 and P40. So that can help you, especially in the context of something in the adenocarcinoma family. If you see an adenocarcinoma in the skin and it's strongly P40 positive, it's a good chance that it's coming from the skin, from a sweat gland or sweat duct origin, not a metastasis from the visceral organs, because most adenocarcinomas of the viscera are negative for P40 and P63, with the exception being that some lung adenos can express P63, which is why we use P40 in the first place, right? Is because of my understanding historically is it's pulmonary pathologists and the necessity of distinguishing between adenocarcinoma and squamous cell carcinoma, that's where they started using P40 because of its better specificity for squamous cell versus adeno in the lung. So in the skin, remember that squamous cell carcinomas, basal cell carcinomas, seborrheic keratoses, all of those should usually have P63 and P40 expression. And most sweat gland and hair follicle and sebaceous tumors will also. Now, there are some exceptions. And one of those big exceptions is mucinous carcinoma, is usually negative for P63 and P40. And also apocrine carcinomas is variable. They sometimes will have some staining, but not always. So here we can see that the mucinous carcinoma is negative for P63, as we would expect. But the endocrine mucin-producing sweat gland carcinoma, we can see that the inner cells, probably the cells that the mucinous carcinoma arises from, that inner layer of cells, they're analogous to the invasive mucinous carcinoma component. But the basal layer here is staining nicely with P63. That is basically evidence that this is an in situ lesion arising in a dilated sweat duct. And then, therefore, the invasive component here, logically, is arising from this in situ precursor, and therefore it is primary to the skin and not a metastasis. So unfortunately, I don't have pictures of the endocrine markers in this case, but they will stain very nicely. I feel like they are not always diffuse. Sometimes it's patchy, as is often the case, I think, with neuroendocrine markers. So you may have to look carefully. But INSM1, insulinoma-like protein 1, is really nice. It works very nicely if you have that in your lab. So that is the importance of this case, is go look for the precursor lesion. And sometimes it will be large, like this, but other times you might only find a little, where was it, a little area. Is it cut through? That's probably a tiny, tiny bit of it there. but go look closely because it can be a clue to help you identify. Or if you see the mucinous carcinoma and on immunostain, you can find that layer. So I will often, if I can't see it on H&E, I will sometimes do P63 or P40 to look for that in situ component to confirm the skin origin of the lesion. All right? So the question here in the chat box is, what's your opinion regarding endocrine mucin-producing sweat gland carcinoma versus primary carcinoid of the skin reported by Dr. Keisuke Goto, who's a friend of mine from Japan? We wrote a nice paper, well, I thought it was nice, but I'm biased because I was a co-author, but we wrote a paper together on a really nice case of cutaneous sparginosis, which is a rare parasitic infection that occurs. It can occur all over the world, but is most common in some Asian countries, I think because of dietary eating of raw reptile or amphibian meat, like raw snake or frog meats, which I try not to do. But anyway, he posted a case some years ago on Facebook, and I said, we need to write this up. It's beautiful. And so we did, and that was fun. And it got published actually on the cover of the Journal of Cutaneous Pathology twice on accident, 2 months in a row. So I actually have both. I want to frame them one day. I only put it one time on my curriculum vitae. Well, I put both references, but I only count it as one paper. But I thought it was cool. It was just a glitch in the publishing process, but I thought it was kind of fun. So now you know that story. But anyway, Dr. Goto writes really excellent papers. I have not read his paper on primary carcinoid of the skin. I have heard rare cases of carcinoid in the skin, and I'm not sure if there is a relationship here or not. I have also seen rare examples of metastatic neuroendocrine carcinoma in the skin arising from internal primary sites. And I've also seen some rare examples of metastatic small cell lung cancer in the skin. But I feel like it's a little bit different than this here. But I don't know, and I've not read his paper yet, which is another thing on my to-do list when I get back home, is to read that. Thank you for that question. All right, so that's this entity. So it's a bit of a long name to remember, endocrine mucin-producing sweat gland carcinoma. And I can't remember in my handout if I put in,
Gerard,
yes?
as I am not a dermatopathologist, I've never seen this entity. And I don't know in which cells the endocrine marker are positive.
So the question is, in this entity, where will the endocrine markers be positive? Usually, they will be expressed in all of these, or sometimes it will be, again, patchy. It may not be totally diffuse, but you'll see staining here.
But it will not be positive in the invasive component?
Oh, the invasive component can be positive. That's the question. So the invasive mucinous carcinoma can be positive for neuroendocrine markers. So in the past, I've thought, well, if you have a mucinous carcinoma of the skin and it's neuroendocrine positive, to me, that suggests that maybe it could be arising from this. But someone had pointed out to me that neuroendocrine markers have been reported in mucinous carcinomas of other sites, like the breast. I have not done intense reading on that, and I'm not a breast pathologist, but I have been notified by other people that that's not a totally specific feature, that you can see it. But I have seen mucinous carcinomas near the eye that had no obvious in situ precursor, but that had strong neuroendocrine markers. And I felt like that was probably further support. But then like I said, other people have said, well, in other parts of the body too, you can have neuroendocrine markers in mucinous carcinoma. So it's a bit of a challenging area. The good news is that prognostically, these are indolent. Both the invasive and the in situ components here have a good prognosis and can usually be treated successfully with surgical excision. I think the bigger problem is when you start worrying about metastasis, that creates a lot of extra anxiety for the patient, a lot of extra workup, and sometimes that needs to be done, but that can be a difficulty for the patient and the treating physician. And this one is a 50-year-old man with a large, thick keratotic plaque on the plantar foot. Let me see where okay. Let me show you the gross photograph first, which is really convenient when you get to see this, but most of the time when this tumor presents, you do not get this information. You have to look at a small biopsy and figure it out, which can be impossible. Here's what we're dealing with. This is the acral skin, very thick, And you can see this kind of invaginated area here, kind of papillomatous, friable surface, partially ulcerated, and very thick. All that white there, that corresponds to elongated, very long reedy ridges, which are what we're going to see microscopically in a moment. It's a view of the whole lesion. And that's what it looked like before it was sectioned. So it looked like a very large ulcerated mass on the plantar foot. Okay? Microscopically on the excision, here's the background skin, and then you see that it invaginates in, and it has a surface that has a very warty, verrucoid appearance. And then there are these very long extensions of reedy ridges. I'm going to show you a few different sections to give you an idea of the range of features you can see in this entity. This can be very, very difficult to diagnose. I think this is very classic and characteristic. The reedy are extremely long and push deeply into the dermis. There's also some scar here, and if I recall correctly, I think this was the case. This patient had had previous procedures, I think, treated with scraping and curetting of the lesion, which the tissue was then discarded rather than examined pathologically. No, please don't do. I have to remind, thankfully we rarely see that, but every once in a while you'll find someone that's, scraped or shaved out a lesion and tossed it into the garbage, which is awful. So, and then it continued to recur, and finally someone removed it, and this is what we ended up with. Here's another area, and you can see that the reedy are not only long, in some areas they're very dilated and kind of bulging down, way down into the dermis, almost down to they're almost down to fat, almost to the sub-Q. Here's another look at the other side, and you can see here how deeply the lesion extends. And more of the same. Okay. So, if you have a biopsy from the surface, you're going to have a problem. Because, it's not perfect for a verruca, but it can look quite like a verruca in some cases. One of the clues here that maybe you're not dealing with a verruca is that the parakeratosis is very prominent and diffuse. Now, sometimes verruca, as you probably know, normally the parakeratosis is most prominent over the papillary tips, the finger-like projections at the top of the wart, and then there's kind of zones of orthokeratin in between. So that kind of alternation between orthokeratosis and parakeratosis can be a useful clue. But sometimes, especially in irritated or inflamed verruca, you can get much more diffuse parakeratosis. So that feature alone is not perfect at distinguishing here. But in this entity, which by the way is verrucous carcinoma, is basically a very bland, well-differentiated subtype of squamous cell carcinoma, but it behaves differently than other squamous cell carcinomas, so I think it does deserve its own separate name. The parakeratosis is very diffuse, and it tends to extend way down into these valleys between the papillae. And it's very bright pink, vivid, bright color of the keratin that comes off of the epithelium. So that's one clue. These very these dilated clefts here going down, filled with dense pink parakeratosis, and then very thin papillae pushing up. Okay, that's one thing. Number two, the most important thing to me is how deeply the reedy ridges go. Verruca on the palmar and especially the plantar surface of the foot, they do tend to be endophytic, to be pushed down. And I kind of think of that as the pressure of walking on the bottom of your foot. The wart is getting smashed every step you take deeper into the dermis. So it will be sometimes sitting kind of in a cup-shaped invagination with the fingers or the papillae of the wart sticking upwards. But you're not going to see these reedy, deeply diving down like this. But the problem is that you often need an excision or an incisional biopsy down to the level of fat to be able to make this diagnosis with certainty. Because verrucous carcinoma does not have cytologic atypia. almost by definition, it should be very, very bland cytologically. So these long, protruding, and bulbous, dilated, reedy, invading, pushing invasion into the deep dermis is the characteristic key to recognize the diagnosis. But cytologically is extremely difficult. I mean, that looks, to me, benign or reactive at most. It does not look ugly and cytologically malignant. If it looks cytologically malignant, then you probably just have a standard squamous cell carcinoma, which sometimes do have a verrucous or warty papillomatous surface, as we see, particularly in elderly sun-damaged people. I see squamous cell carcinomas that on the surface look very much like a verruca almost every day in my practice, okay? But here we have a very bland cytology. Some people have pointed out that there will be an increased mitotic rate along the basal layer, although I don't really know, I mean, what's increased mean? There's lots of mitoses along the basal layer in normal skin, and especially in reactive epithelium. So it can be very hard to tell this apart from verruca, and also it can be very difficult to tell this lesion apart from reactive squamous epithelial hyperplasia or pseudoepitheliomatous, pseudocarcinomatous hyperplasia that we can see in reactive processes. You know, keratinocyte lesions are common in dermatopathology, so it seems like they should be basic and simple. Bread and butter, as we say in English, right? Every day. But I still struggle every day with sorting out, is it a wart with reactive atypia or is it squamous cell carcinoma? Is it an inflamed seborrheic keratosis or is it an inflamed squamous cell carcinoma? Is it reactive atypia next to an ulcer, or is it squamous cell carcinoma? So if you struggle with that, you're in good company. Well, you're in company with me, I'll say. I don't know if it's good or not, but you're not alone, because I kind of felt a little embarrassed about that for a while in practice. I thought, these are common lesions. I should be able to tell. And then I realized that many colleagues, much more experienced than me, struggle with it too. So the struggle is every day and real, and there's not much we can do usually in the way of immunohistochemistry or other things. It's really getting a big enough sample and the morphology. So I think I talked to some extent in my handout in the book about how I deal with those situations, and I've also published a book about dermatopathology that I go into detail about that, because it's something every day I encounter dealing with keratinocyte lesions and how to know when they're malignant or when they're mimics. And I think it's actually much more complicated than people recognize at first glance, especially with this lesion that lacks atypia. So verrucous carcinomas, all the features I discussed here, they have been described in a few sites. In the oral cavity, where they look, to my eye, a little bit different. I am not an oral pathologist, but I've worked with some oral pathologists, and they have similar features, but they're not quite as dramatic to me in the oral cavity because there's not as much tissue there, not as much space for them to get as large. In the anogenital area, they can be seen. And then the most common place I see them is on the foot, usually the plantar surface of the foot. So a few problems here. Number one is in the anogenital lesions. Historically, there has been a lot of confusion between verrucous carcinoma and the so-called giant condyloma of Buschke and Lowenstein, right? So people in the past have oftentimes made those as equivalent terms, that they are the same thing. But more recently, I think there's been a trend away from that and to sort out that there are two different situations here. Verrucous carcinoma, despite its warty appearance, most studies have found is not associated with HPV. Is always, as always in Dermpath, there is maybe some debate over that, but I think the most common modern thinking is that these are independent of human papillomavirus, despite the warty appearance. Whereas giant condylomas of the anogenital region are truly HPV-driven condylomas that are very large. And they particularly happen in HIV-positive patients or other patients with immunosuppression. And they also have a tendency sometimes to evolve into true invasive squamous cell carcinoma. So both lesions are significantly problematic. They are locally destructive. They are problematic lesions that need to be treated. So maybe the distinction is not as important as we make out, because a giant condyloma, even if it's HPV driven, is a big problem for the patient. Sometimes they can be massive, truly disfiguring. But these lesions are problematic also because of their striking tendency for aggressive local recurrence. And this particular case is the one that taught me that very well. This was removed by an orthopedic oncology, a sarcoma surgeon who did this surgery. And I remember because I looked at the margins and I said, well, here's tumor, right? No problem. And this looks like reactive, to me, reactive epithelial hyperplasia, what we call lichen simplex chronicus, right? Or prurigo nodularis. It's the change that happens to skin when you scratch or pick at it. And many different keratinocyte lesions, patients will, irritate, right? I mean, if you had this ulcer on your foot, you would mess with it and you would do things to try to make it feel better or make it improve. So you often see reactive thickening of the epidermis adjacent to verruca, squamous cell carcinoma, actinic keratosis. Every day I see this, okay? So here I said, well, there's no way this is tumor. This looks reactive to me all the way out to the margins. And this clearly is tumor in here. Cytologically, though, impossible to tell the difference. That looks the same to me as that. Is only the architecture. So the margins were negative here. And then, 9 months or a year later, recurrence. Even though the margins look very widely negative. And if memory is correct, they removed again, margins look negative, and it recurred again. So at least 2 recurrences, and I've lost track of the patient since this was some years ago. But even in retrospect, I thought maybe I made a mistake. So I pulled the slides and I looked with my colleague and we said, we do not see anything that looks like tumor at the margin or even close to the margin. And yet it recurred. So I don't know for sure the answer to this, but what I suspect is that sometimes there are areas here that look identical to reactive hyperplasia that are actually part of the carcinoma. And to me, there is no possible way to sort this out. So what I've started doing in my reports, I don't know if anyone else does this, but from cases like this, I have in my report said that sometimes areas of tumor can look identical to reactive epithelial hyperplasia. I don't see any obvious tumor at the margin, but I can never be totally sure with verrucous carcinoma. To kind of help both the surgeon and the patient understand, to have a little bit of, to understand that there's always still a possibility of recurrence. It helps to manage the expectation of the patient and the treating physician to make them know, yes, it looks like we probably got it all, but with this tumor, we can't really be 100% certain. I think that sometimes helps to make it less frustrating for the patient and surgeon when a recurrence unexpectedly happens. It was a very unusual case, an informative case in that way. So these tumors recur, but they do not metastasize unless they convert to true, like higher grade squamous cell carcinoma, which can sometimes happen, that you can have a bland verrucous carcinoma and then have an uglier true squamous cell carcinoma arise out of this. I've not seen that often, but a couple of times, and my oral pathology friends have told me it can happen. And then once you have a true, full-form squamous cell carcinoma, metastasis is possible then, of course, but I've never seen one of those metastasize in my practice. Usually the issue is local control. And it's a problem because where it occurs is an area where you don't want to have a large surgical margin in the genitals, the perianal region, the bottom of the foot or the mouth, right? So it is a significant challenge to sort these cases out. But it's good to be aware of and to know. And sometimes if you have a small biopsy, getting the clinical information can be crucial. Because I had a case once where I looked and I said, I think it's verruca. And then they showed me the MRI and the tumor was pushing all the way down to bone on the bottom of the foot. And I was like, well, I don't think it's a verruca anymore. So it can be impossible. I'm sorry to bring you so many impossible cases, but this is the practical struggle, right? It'd be a lot more fun to just do basal cells and seborrheic keratoses, but you guys already know how to do that. So these are the ones that can cause you to lose some sleep. Any questions about this? Is there something in the chat?
Yes, yes.
Oh, so Key 67 or P53 and P16, are they useful? I don't know. I've not applied those to this setting in my practice. I'm sure that people have tried them. I think Key 67 in keratinocytic lesions is challenging to interpret because it's always positive along the basal layer. It's a question of how much is enough. And that question is very subjective, right? If you want it to be benign, you say, I think it's kind of low. You want it to be cancer? Oh, yeah, it's increased for sure. I do, and I don't use P53 very often. The one time I find P53 useful is in the setting of lichen sclerosus, when there is atypia and acanthosis of the epidermis, particularly in the vulva, and I'm concerned about differentiated vulvar intraepithelial neoplasia, or DVIN, which I find, I've seen quite a bit of it lately, actually, and I think that it's out there and it's more common than we realize. It is extremely difficult to diagnose morphologically. So that's a different topic, but if you ever see atypical stuff over top of lichen sclerosus etytrophicus, try a P53. You can do Key 67 also, but the P53, if there's diffuse basal layer staining or complete loss, then that's concerning for dysplasia that's caused by lichen sclerosus. And I have seen those progress to invasive squamous cell carcinomas. Those are independent of the HPV pathway of vulvar squamous carcinoma. So again, a topic for a different day. And I think I did a video on this, a short video, but I think it's part of a bigger compilation. Eventually, I will have it split out into its own video, but I find that very difficult. But aside from that, I don't use P53 very often, and I'm not sure if it would work here. Does anyone have a comment on that in the audience? I'm happy to learn from your experience because oral pathology, yeah, I've noticed my oral pathology colleagues love using P53, and they use it on lots of things, and I'm always like, well, okay, I don't know what to do with it, with P53. Like, how much is enough? Like, diffuse? So for verrucous carcinoma, will it have increased, like, diffuse P53 or no?
Maybe it's diffuse or totally negative.
Okay, so it can. So the comment from the audience was that in oral pathology, at least, P53 potentially can be helpful here. So maybe I should start trying this in my practice. Thank you for that comment. I appreciate that. A 45-year-old man with a polypoid scrotal mass, clinical impression, condyloma. Oh, so amazing. So I remember this case because it was my first case of the day, and I sat down at the microscope with my residents, and I said, whoa, look at that I like to hold the glass slide up just to look at it for a minute without the microscope, and I was like, I think that's going to be this entity. And I thought, surely not. And it was. I couldn't believe it. I mean, if you know what this entity is, it's fair to think of, but I thought, it's not common. And so I looked like an all-star for my residents that day. But there's plenty of times I play that game and I'm totally wrong. So you got to take, like we say, I don't like baseball very much. Some Americans love it, but I don't. But they always say you got to, take a swing to make a home run. But you can strike out a lot too, and I strike out plenty. So keeps me humble for sure. Working with trainees is wonderful. They keep me humble and also teach me a lot because they ask difficult questions that I don't know the answers to. So this is a polypoid lesion. It kind of has a warty, polypoid condyloma-like appearance from low power. But when we go closer, it's not, even though it has that rounded kind of knuckle-like protrusion, it's not as much thickened keratinocyte epithelium as you usually see. The rounded knuckle protrusion of condyloma acuminatum is usually composed mostly of keratinocytes. Occasionally, I've seen condylomas that have a lot of a dermal collagen in the middle, but I feel like more often not. More often, it's the acanthosis of the epidermis that's proliferating and making the polypoid extensions. So the thing I want to point out, though, is look from low power. Look at that bright pink all on the surface and all down in these invaginations between the papillae, that bright pink keratin. And it's parakeratosis with a lot of scattered neutrophils in this case. And it's coming right off of the stratified squamous epithelium. No granular layer, just this direct transition from keratinocytes into this bright, brilliant, blazing pink eosinophilic parakeratosis. So some people have mentioned, and I learned this from a friend on Twitter, actually. I learned a lot of stuff from Twitter. It's fantastic. If you are a pathologist and you don't use Twitter, you are missing out. There is incredible, huge community of I keep a list of all the pathology accounts I find on Twitter manually. I add to it every day. I'm kind of obsessed at this point, so I've just accepted that this is true. I'm married to a psychiatrist, so she can deal with that one day. In any case, my wife is a child psychiatrist. In any case, the point is on Twitter, there's this huge global community of pathologists that share all these amazing cases. So I do a lot of teaching on Twitter, but I learn so much from the things that colleagues share and the little tips and the tricks that they use in practice. It's just beautiful. And it's a very welcoming, friendly community. You guys have a French pathology Twitter all-star back there. Aurélien is, what do you have, 2,000 followers now? You have over 1,000 followers, right? He has many, many followers, so. All right, so go check out Twitter if you want. And if you don't know how, I have a guide, a website that teaches you how. If you just Google social media guide pathologists, it'll be the first thing on Google, and it will teach you everything about how to do Twitter and Facebook or whatever, okay? So that's my pitch for using social media. So one of my friends, though, on Twitter said, it looks like a wart set on fire. Like you lit the top of the wart and it's burning with fire because of that hot, bright keratin. And I love that analogy. It's so beautiful, and it works very well for this lesion. So warty surface, bright pink keratin, and when you go close to look, the key is in the dermis. Let me find a close enough area. Oh, I think this one didn't scan quite as close as I wanted. But the dermis here is filled with foamy, bubbly histiocytes, lipid, vacuole-filled histiocytes, or xanthoma cells. I'm going to pull up my PowerPoint because I think I have a closer picture. Let me see. I had to hunt around for a while to get the best area. See? Bubbly, foamy histiocytes filling the papillary dermis. So putting all of that together, this is a characteristic example of verruciform xanthoma. And despite the xanthoma name, these are not associated with systemic lipid abnormalities, right? These are not hypercholesterolemia. They're not hypertriglyceridemia. The thought is that the lipid accumulation here is a secondary reactive phenomenon that for some reason occurs in the context of this lesion. They're benign, and they're important to know for a couple reasons. Number one, they're a mimic clinically of condyloma acuminatum. All right? And number two, something that no one had ever taught me but that I discovered in practice is that the keratin pattern here is very similar to what I just showed you on the top of verrucous carcinoma. Papillomatous surface and very bright pink parakeratosis down in between. And the way I learned this is that once I saw a lesion on the penile shaft, and it was a shave biopsy, and I said, oh, bright keratin, and there was a little foamy stuff in the dermis, and I said, I think this is verruciform xanthoma. And then later we found out this patient had a known history of carcinoma on the penis, and it turned out on excision it was a verrucous carcinoma. Thank goodness. They knew more, and they went back and excised the lesion anyway because I thought it looked like a benign thing. So on a small biopsy, do keep in mind that verruciform xanthoma can have a lot of similarity to verrucous carcinoma. And the clinical information usually is helpful there because these are polypoid lesions. And the vast majority of these occur in the anogenital area, but they can also occur in the oral cavity. And I have seen one example on the forearm. Who knows why? So maybe rarely at other sites, but the majority are anogenital or oral cavity lesions, and they're benign. So they're kind of beautiful and benign, especially when you have an entire one removed like this, but do make sure that on a shave you keep in mind the possibility of verrucous carcinoma as a mimic. Usually in verrucous carcinoma, I do not see foamy histiocytes in the dermis. So that one case had a few, but it was a small biopsy and I thought it looked really good for this. Usually if you see a lot of foamy histiocytes, probably what you're dealing with is verruciform xanthoma. And in the handout, this paper is fantastic. Mei Chan is a really wonderful dermatopathologist from University of Michigan, I believe is where she still is. And she wrote this. Two of my partners and I were invited to do a guest edition of Archives of Pathology and Laboratory Medicine. And it was published in, I think, the July and August 2019 editions. It's a two-part, 2 months in a row. And all of the articles are dermatopathology for general surgical pathologists. So we invited different authors to write, not about esoteric stuff, but about things that can help general pathologists who have to see some skin. So these are freely available on the Archives website, Archives of Pathology and Laboratory Medicine. So I encourage you to check those issues out, and we hope that our goal, again, was that they would be practically useful for pathologists in practice. And I found this paper by Mei Chan, which we invited her to write, to be particularly just beautifully done. The image quality is fantastic. She has not paid me any money to say this. I looked at it and I was like, this is the way a paper should be written. Like, I hope I can write papers that good one day because it's just perfect. And it talks about the difficulties of the verrucous and condyloma-like squamous lesions in the anogenital region, which I think is a very challenging area of gynecologic and dermatopathology. So that's a great area there. And a lot of times when I encounter difficult squamous proliferations in the anogenital region, I often consult not only with my dermatopathology colleagues, but also my gynecologic pathology colleagues. And I feel there's a lot of overlap in the vulva particularly, and in the other anogenital skin, because even in the male genitalia, the squamous proliferations there are very similar and analogous to the ones in the vulva. And I think gynecologic pathologists have a particular skill in dealing with and grading squamous atypia and knowing the terminology that's currently used for HPV-driven lesions. So I learn a lot from them, and I feel like the best diagnostic criteria and terminology can be used when we work as a team. So I often will show them. We wrote a paper just a few months ago, I think it was, 6 months ago, published about consensus between gynecologic pathologists and Dermpath for vulvar biopsies. I think particularly in women that have vulvar lesions, and again, this is a little bit of a tangent to the side, but women who have vulvar problems and get biopsies usually have a significant morbidity. They've been suffering for a long time. Those biopsies are difficult to interpret. And yes, you can just be descriptive, but I want to do the best I can to help those women get the right diagnosis and treatment. And so anything that we can add to accomplish that, I think, is worthwhile to spend the extra time and effort. But again, that paper really is great, and I hope you'll check it out. And I'm really grateful for Mei Chan for writing that paper. All right. Okay, verruciform xanthoma.
But in this tumor,
Yes?
which cells are at the origin of the tumor? The squamous cell or the histiocyte cell?
The thought is that the keratinocytes drive the growth of this lesion. And I'm not sure if it's a true neoplasm or a reactive, and I don't know if that's fully understood. But the thought is that the xanthomatous histiocytes are secondary, that they occur for some reason as a secondary accumulation, rather than that they deposit and then the keratinocytes grow. The thought is that they come second and fill in those spaces in this lesion. I'm not sure how to make this bar disappear, but I'm afraid to click it. I don't want it to close the hole. We'll let it be. It'll be okay. This is a 75-year-old man with a large ulcerated nodule on the dorsal hand. Okay? So here's one area. Here's a closer look. Here's another area. Not good. Not good at all. I'll show you all 4 of the slides, and then we'll go back. Here's more. And as you can tell, this is a very large specimen. This was also taken out by a sarcoma surgeon, an orthopedic oncologist, because of the large size and the depth of involvement of this lesion. And you can see that, we've got skin here and in dermis. This used to be subcutaneous, but is now mostly fibrosed. And then look at that. This is tendon. This is part of the extensor tendon, and the tumor is all the way down, wrapping around the extensor tendons on the dorsal hand. There's not a lot of depth between the epidermis and the bone on the hands, on the dorsal part especially, or on the digits. So when a tumor gets bad there, it can get really bad really quickly. All right. And here, this was from another area. This patient had multiple lesions that were, he had actinic keratoses, squamous cell carcinoma in situ, or Bowen's disease if you prefer, and had multiple lesions in addition to the large one that I showed you there. Okay. So the thing about this case that struck me is that the patient has a very nasty, bad squamous cell carcinoma. Very infiltrative. I think I would call it moderately differentiated. Differentiation is somewhat subjective, and very infiltrative, most characteristically. You could also wonder, could there be some sweat duct differentiation? In this case, we felt that the vacuoles were artifactual and not true duct formation. But I think it would be fair to think about if there could be a sweat duct carcinoma. But here, much of the lesion looked very much like an aggressive squamous cell carcinoma. But what struck me when I saw the case was areas like this. It's common to have brisk inflammation under squamous cell carcinomas, or even under basal cell carcinoma, actinic keratosis, squamous cell carcinoma in situ. I often see dense inflammation, lymphocytes, and plasma cells particularly, right underneath those tumors. But here, in addition to being right underneath the tumor, there were areas well away from the main tumor mass that had a dense infiltrate. And when I went down to look at them, I thought, wow, look at how perfectly round those lymphocytes are. I will not lie to you. I'm not a big fan of hematopathology. I find it very difficult, and it just doesn't click with my neurons, okay? I'm thankful that I have really smart colleagues. I have a colleague down the hall from me who is a dermatopathologist who specializes in skin lymphomas, and we actually have a little trading system. When I get a biopsy that I'm like, this is gonna be a heme path entity, I go and trade it to her, and she'll give me a spindle cell tumor or a vulvar biopsy or something, and so we have a good system, it works. I'm okay not being an expert at this because it's really hard for me. But I thought, wow, those look kind of fascinating because of the perfect roundness. I've recognized that I really like cells that are perfectly round. I love glomus tumors because something aesthetically about that perfect roundness is just satisfying to my soul. I don't know, maybe you're different. But when I see lymphocytes that are perfectly round and small, I think of chronic lymphocytic leukemia or small lymphocytic lymphoma. And that's what this patient had. So unfortunately, and I wish I would have, this was a long time ago, and I did not take pictures of the stain, but these were diffusely positive for CD20 and for CD5. And we didn't at that time have LEF1 or those markers, and I think cyclin D1 was totally negative. And the main thing, as I said, this looks like CLL, SLL, chronic lymphocytic leukemia. So when you have that thought, the first step is look at the patient's chart and see if they have a history of that. Because sometimes I had one just recently where I looked and I thought, this looks kind of like CLL, and sure enough, patient had a known history for a long time. They just didn't write that down on the sheet, because they weren't worried. It was a basal cell carcinoma, but it had a background of chronic lymphocytic leukemia, incidentally. So one, check the history. Number two, check if they've had a complete blood count, because then you can look and see if they have lymphocytosis. Right? That can be a useful clue. Remember that squamous cell carcinoma is very common, and so is chronic lymphocytic leukemia in the same population, elderly patients, right? So it's something that's out there. I have seen this multiple times, and I've seen a couple of times where it was not known previously, and this is one of those times. And when I called up the surgeon and said, hey, this patient has a bad squamous cell carcinoma, all the way down to tendon, I think there was perineural also in here, if I recall. And I said, and also they have background chronic lymphocytic leukemia, and I said, heme path is working it up further, and you should check their blood and get them seen by by oncology to do bone marrow or whatever additional workup is needed. So he said, wow, he said, that's really interesting because this patient has numerous squamous cell carcinomas on his face, like as if he were a transplant patient. And as you know, transplant patients, because of the immunosuppression, have a tendency to develop many squamous cell carcinomas, and sometimes they can be very aggressive squamous cell carcinomas. And so he said, this patient almost seems like a transplant, but has never had a transplant. And I said, it's because his immune system is wiped out by being overrun by chronic lymphocytic leukemia. And so in this case, that's exactly what was happening. They did further workup. His bone marrow was almost completely effaced by chronic lymphocytic leukemia. If I recall correctly, he had like large cell transformation or so-called Richter transformation. And then let me pull these up to see if I can show you. So unfortunately, the patient had to have a partial amputation of their hand because even with that very large excision, margins were still positive. And so they went back and they partially amputated the hand, and they also took out regional lymph nodes, which were enlarged. And, I see a lot of cutaneous squamous cell carcinomas, but it's pretty rare overall to see ones that metastasize to lymph nodes or distantly. But this patient had, I think, 25 lymph nodes removed. 20 of them were positive for squamous cell carcinoma. Very aggressive behavior. And here is the lymph node filled with squamous cell carcinoma. And in the background, the node architecture is effaced by a sheet of small B cells, completely overrun by chronic lymphocytic leukemia, small lymphocytic lymphoma. Here, this was one of the, and I don't know a lot of hematopathology, but when I see diffuse sheets of cells, lymphocytes, that's bad, right? I know like lymph nodes not supposed to do that. Should have like some germinal centers, and you can see the little, I think they call them proliferation centers, right? Those little pale areas. Any hematopathologist here probably knows. So I thought this was a very, it was a case that made me really aware of how problematic this can be. I don't know the final outcome of this patient, but I suspect that it was not good, unfortunately. And there have been some publications about this, that patients with CLL, SLL, chronic lymphocytic leukemia, that they have a tendency to have more aggressive squamous cell carcinomas. And I thought this was a really, a very eye-opening case for me. So what it's taught me is now I look more carefully, where did it go? When I see lymphocyte inflammation right under a squamous cell carcinoma or basal cell, I don't go and do CD20 on every single case. I mean, you can if you want, but I feel like I see it all the time, especially if it's mixed with plasma cells and other stuff. But if I see a diffuse, very homogeneous, small lymphocytes, particularly if I see them like this, perivascular, away from the main tumor, out at the side, I've seen that, and now multiple times by looking and staining, I've picked up CLL in the background skin. And CLL is not curable, is my understanding currently, but it can be treated, and sometimes that treatment can improve quality of life and delay the onset of more aggressive side effects of that disease. So it's worth identifying and picking up on earlier rather than later. And so I thought I have a low threshold. So what I do is if I think it might be there, I use a panel of 3 stains, CD20, CD5, and CD3. And the goal of that is to sort out CD3 stains the T cells, CD20 stains the B cells. If they're just a mixture, it's probably reactive. If they're predominantly 20 positive and co-express 5, then it's probably chronic lymphocytic leukemia, although of course there are other CD5 positive small B cells like a mantle cell lymphoma, which I used to say you'll never see mantle cell lymphoma in the skin. Well, If you do it long enough, you will. And I did see a case of a patient who had an internal systemic mantle cell, went to the skin, and without the history, I wouldn't have known. So this is why hematopathologists have a lot of job security going into the future, because it just keeps getting more and more complicated. I mean, I only graduated residency 11 years ago. There's all sorts of stuff that didn't exist back then in just 11 years. It's kind of overwhelming sometimes. So look for this in the background. See it? Look at that. And then consider doing that. So then if I do see CD5 positive B cells, then I usually will consult with my hematopathology colleagues, and then they can get a patient's a clinical oncology workup. Okay? Any questions? Oh, here, actually, before we go, I did take a close-up picture of the cytology that I had, not from a digital side, but to get really close with the hydri. And you can see that kind of a football pattern, or soccer ball to Americans, spotted, speckled kind of pattern of clustered chromatin condensation that is supposed to be very classic for chronic lymphocytic leukemia. Although I have seen cases that were not as perfectly round and did not have clear-cut, so the clear-cut nuclei that looked like this. So don't expect that every case will look perfect. You have to have just the right preparation and sectioning to get a really good classic example. But I've seen ones that were kind of not nearly as pretty and classic here. So I do have a low index of, a low threshold for doing stains if I'm uncertain. Okay.
There's a few comments.
Okay. Let's see. I see training interest. Someone said that they're a hematopathologist interested in dermatopathology. God bless you. We need more people to come into to Dermpath that like hemapath. And then you would add CD23 if the phenotype is 20 and 5, and CD23 can raise the possibility of a B CLL. Thank you, Dr. Iselin, for that comment. And then the question is it sort of a homing phenomenon? Are the cells homing into the squamous cell carcinoma? I don't know. It's a good question. Are these cells there because of the squamous cell? Or are these cells there throughout the patient's skin, and it's just that the squamous cell carcinoma got sampled? I suspect that usually it's probably the latter, because I've seen times where there clearly was a basal, and you just see the perivascular infiltrate in the background skin. And also in those times, I think usually, if the patient has a known history of CLL, whether or not there's some incidental involvement of the skin is probably not really clinically useful information, right? It's different in a patient with acute leukemia, right? Acute myeloid leukemia involving the skin is a serious problem. It's a medical emergency, basically. But in a patient with known CLL, that's maybe they're under treatment, but they're going to always have some circulating CLL cells. It's not surprising to me that sometimes those cells incidentally settle into the skin. I mean, they're part of the normal lymphocyte component for that patient now that they have it. So I suspect it's an incidental finding, but perhaps there is some homing going on. That's a great question. And then the finest thing is, the squamous cell carcinoma has sometimes a spindle cell morphology. Is it worth mentioning? Well, it is a good question. Yes, if you see spindle cell squamous cell carcinoma, to me that represents poorly differentiated, kind of sarcomatoid or spindle cell squamous cell carcinoma, I think of as analogous to poorly differentiated. I can't recall if this lesion actually had really good spindle component. Maybe it did. I felt like much of the spindle cell in the background was reactive myofibroblast, kind of desmoplastic stromal response. But sometimes it can be hard to tell them apart, and you can try to use immunostains, although spindle cell squamous cell carcinoma sometimes loses its keratin markers and can lose also even P63 and P40 sometimes. So yes, it is worth mentioning. Here, it didn't really seem to matter. This was clearly aggressive, regardless of what name or grading we put on this. This was an aggressive bad tumor. But yes, usually if I see a true spindle cell squamous cell carcinoma component, I'll report it as poorly differentiated squamous cell carcinoma with spindle cell features. That's the terminology I use. Number 9. Firm white and brown plaque on the scalp of an 80-year-old man. Well, the first thing I would like to point out to you is this is definitely an old person, an old, sun-damaged, fair-skinned adult, okay? An old white person. And as a hopefully future old white person, I say that with love and kindness because I have a lot of older white relatives who have a ton of sun damage. And I see these kinds of patients all the time. When you have a patient who has extensive solar elastosis, for anyone junior watching this, that's elastosis. It's gray to blue elastic fibers that have formed a mat that have replaced the dermal collagen. Sometimes you'll have a little collagen in the papillary dermis, but all the pink reticular dermal collagen that should be here is gone. It's been pushed way down by years and years of sun damage. You don't get this by going to the beach on the weekends. You get this from every day, hours and hours of chronic, full dose sun exposure for many decades, okay? Look at the elastosis, and then suddenly it disappears. It gets wiped out. There's a little bit of it left. But there are areas where the elastosis is getting replaced by something else. So that's a clue when you're looking at a biopsy of someone with a lot of solar elastosis. If there's a zone where the elastosis is interrupted or replaced by collagen, that means it's new collagen. Collagen that was not there when the patient was born. Collagen that was placed there after the patient got old and sun damaged. And then you need to ask yourself, why? Why is the collagen there? Did they have surgery or biopsy and this is now scar? Do they have a tumor that's producing collagen or an invasive tumor making a reactive desmoplastic response? So that's an important clue when you have cases like this, is that the collagen is getting distorted by, the elastosis is getting distorted by new collagen here, and that's because it's being deposited in response to the tumor, okay? This tumor has, from low power, a couple of different areas. We have a hypercellular nodule down here. Then we have areas like this that are very pink and look almost scar-like or fibrotic. And an area here that's kind of a mixture of those patterns. So let's look closer. This area looks very much like fibrosis. These cells are plump spindle cells intervened by collagen, and in some areas maybe a tiny bit of myxoid material. It gives it a kind of a bluish pink appearance. See, it's not there's perfect pink right here, but these areas are like a little bit more blue, and that's because there's ground substance, hyaluronic acid, mingled in with the collagen in the background. Very similar to me to the appearance you see in scar or granulation tissue. But as you look around, some of the cells are a bit larger and more hyperchromatic, like here. Begin to see mitoses, which of course you can have in scar. But in an older sun damaged patient, if I see something that looks like a scar, I look carefully for significant hyperchromatic atypia. And I also want to know, do they have a reason to have a scar there? Or is this a lesion that's new and there's no trauma? You can't always get that information, unfortunately. So let me show you in the PowerPoint. I've got a couple pictures that are better. Here's an area, perfect area. Spindle cells with that kind of pink and pale blue background. And then look at this, a nodule of lymphocytes. This is the clue that you need. If it looks like scar and you see a little atypia and lymphocyte aggregates in an old sun-damaged person, think of desmoplastic melanoma, okay? The lymphocyte aggregates are the clue. The lymphocytes know these cells are bad, and they're homing in to try to attack them, is the way I think of it. Here's a closer look, and again, it has a very reactive appearance, but there are some cells with pretty significant atypia, maybe mitotic activity here. All right, so that's desmoplastic melanoma. These are relatively uncommon. A small subset of melanomas are desmoplastic. They're very important for dermatopathologists and other pathologists who see any amount of skin to know about because they are deceptively benign appearing sometimes. They can look very much like scar. They can also look very neural. They can look a lot like neurofibroma. I had someone once send me an email and say, I've got this kind of big neurofibroma on an old person's scalp, and it's got some nodules of lymphocytes, and I was like, you're describing desmoplastic melanoma. And then they went and looked it up, and they're like, oh, wow, you're right. And I was like, yeah, that story instantly tells me desmoplastic melanoma. Now, you can have neurofibromas on older sun-damaged people, and occasionally they can even have a little inflammation, but I'm always really cautious, especially if I have a superficial biopsy. I want to know how big is this lesion, what does it look like. Normally, neurofibromas clinically look like a neurofibroma or like a skin tag or like an intradermal nevus, soft, fleshy, usually polypoid or dome-shaped. Desmoplastic melanoma usually looks like a scar, firm, and it may have some pigment or may have no pigment at all, depending on if it has a melanoma in situ component with it. About half of desmoplastic melanomas lack melanoma in situ. So that is difficult. If you find in situ, great. Then you've got extra proof of your diagnosis. If you don't, then you have to rely on morphology and immunohistochemistry. So the problem with desmoplastic melanoma is the main stains that will stain it are S100 and SOX10. The more specific melanocytic markers, MART1 and HMB45, are usually completely negative unless there is a component of more cellular, either spindle cell or kind of epithelioid conventional melanoma. We'll talk about that in a minute. There are some other markers people have proposed, I think P75, there's also CD34, which can usually is more or less negative or only weakly positive here, but will be positive in neurofibromas. I have found, though, in the end that usually I have to look at the morphology and then confirm it with S100 or SOX10, okay? So, and I have some videos about this that go in great depth that you can check out on my YouTube channel if you want. So here we're lucky because we don't just have desmoplastic melanoma, we have areas like this that are very cellular and are composed of hyperchromatic atypical spindle cells with many mitotic figures, obvious malignant cytologic features, and they're arranged in kind of fascicles here, streaming through the tissue. So when you see this, you're not going to think of scar or neurofibroma. You're going to look at that and think of spindle cell squame, spindle cell melanoma, maybe spindle cell angiosarcoma, atypical fibroxanthoma. It looks like a sarcoma, basically. So this is spindle cell melanoma. Now, this is a confusing but important difference. Desmoplastic melanoma is made up of spindle cells, but is not the same as spindle cell melanoma. And its problem is, in the past, those two terms in the older literature were kind of treated as the same thing. And starting around 2004, Klaus Bussam from Memorial Sloan Kettering and colleagues pointed out that if you're really distinct about how to define desmoplastic melanoma, that it sorts out differently from the more cellular, ugly, malignant-looking spindle cell melanoma in terms of the way it behaves. And so anytime we can split out two areas that have a prognostic difference, that's a worthwhile thing to do. So the way to define desmoplastic melanoma is that you have atypical spindle cells, but they're divided by stroma, by collagen. The cells in general, they may occasionally touch each other, but most of them are not touching. They are spaced apart by collagen and loose myxoid background. And when you have that picture right there, and 90% or more of the tumor looks like that, then that is a pure desmoplastic melanoma. And those tumors behave overall better on this, if you're looking at the same Breslow depth or Breslow thickness. Pure desmoplastic behaves better than other types of melanoma of the same depth, okay? They have a tendency for local recurrence, but a lower tendency for distant metastases and lymph node metastases. So I've seen a desmoplastic melanoma grow through the skull, all the way into the dura. The patient was still alive, and the patient did not have metastases. That is a different tumor. Something about it is totally different and unique compared to other types of melanoma. Now, I have rarely seen metastases, and maybe Arnaud can speak to this more about how often, but I feel like I've seen 1 or 2 lymph node metastases, but rarely ever have I seen these patients with distant metastases. Well reported, but it just doesn't seem to happen, or at least I don't seem to get those specimens. How often have you seen distant metastases of pure desmoplastic melanoma, Arnaud?
Several parts of the answer. As described by Klaus Busam, if you have a pure type of desmoplastic melanoma, you will not have. But the history of the description of this entity is through metastasis. That's how it was recognized as a melanoma, because sometimes there were metastases that had the classical version of a melanoma with a pigment that were coming from the common melanoma invasive part of the tumor that you have. So it's usually if you really have pure, so that's why even if you recognize it's a desmoplastic melanoma, I would advise to do the melanA and HME45, even if you know it's going to be negative, but you have to check it's negative, and it can show you the in situ component or maybe a very small invasive component that would give a different prognostic to the tumor.
Excellent. Thank you for those comments. That's very helpful. Yeah, I take that. I have seen one case that I can recall that had a bone metastasis that looked just like desmoplastic melanoma, but the primary lesion looked like regular conventional epithelioid melanoma. So these tumors in the new WHO skin tumor book has some really wonderful writing in there, and particularly about the molecular background of nevi and melanoma. There's a lot of new data that's been put there, and I found it to be a really wonderful resource. And one of the things they mention is that the mutational burden of all melanomas is really highest in desmoplastic melanoma, because they almost always occur secondary to sun damage. I feel like the vast majority that I see are in the scalp or the face of elderly adults. I also occasionally have seen them arising from an acral melanoma precursor, but the majority of them are in the head and neck of elderly people that I've seen. So it's a good tumor to be aware of. And then when you have cellular spindle stuff that looks like sarcoma, then that is a spindle cell melanoma. Okay? Because the terminology is confusing, I have certain comments I add to my report to explain this, because it is confusing historically. And I put that in my handout book, you can see. And also I cite in there Klaus Busam's paper, and he has written many other things since, but I think that's a landmark work that's worth reading to get familiar with this. So let's talk about spindle cell melanoma for a minute. One clue to the diagnosis here, morphologically, I mean, I always do immunostains in this setting, unless there's obvious conventional melanoma. But if it's purely spindled, I do immunostains to make sure that I sort it out from squamous cell carcinoma, atypical fibroxanthoma / pleomorphic dermal sarcoma, and other, because the treatment and prognosis is very different for melanoma. The tendency to make fascicles is very strong in spindle cell melanoma, and those fascicles have a lot of overlap with nests. Look at this area here. These look like fascicles, but when you come down here, they begin to look almost like elongated nests, or like Dr. Sharon Weiss, one of my mentors in soft tissue pathology, sees that they make packets. They are clumped together into little packages separated by stroma. And I like that. So it's kind of like melanocytes like to nest, right? Nevi nest, and spindle melanomas have the same tendency to stick together with their colleagues, their partners, and make these. So that is one clue that helps me, all right? So, and then you have other areas up here that kind of are like emerging between what looks like desmoplastic melanoma in some areas, kind of merging into more cellular spindle cell melanoma, where you're starting to make packets and nests, okay? And so in this case, I called this a combined desmoplastic and spindle cell melanoma. It has both types. I would expect the prognosis of this to be worse, to behave more like a cellular spindle cell melanoma, to have the potential for metastases. These tumors, unfortunately, are often diagnosed when they're really, really thick. The most cases I see, the tumor goes down into the subcutis or even to the galea aponeurotica, or the periosteum of the skull, because they clinically don't look like a classic malignant melanoma would most of the time, okay? They also have a strong tendency for perineural invasion. I can't remember. Oh, no, that's vascular invasion here. See the vessel completely filled with melanoma. Maybe I put a picture in here. I can't remember. Here, there's nerve right here. and then some tumor cells right in the middle of the nerve. So this nerve is kind of entrapped, but usually you'll see it tracking out away from the main mass. Very common in both spindle cell and desmoplastic melanoma to home in on those nerves, and oftentimes the nerves will be completely wrapped and filled up with the melanoma cells, so-called neurotropic melanoma. Okay, so good to know about. All of this stuff in the background is all melanoma, not fibrosis. I mean, there's fibrosis too, but it's all melanoma cells mingled in there. So important entity, and I think this case had some in situ component at the top, if I recall. But again, depending on which studies you read, about half of cases will not. Now, there's a lot of actinic keratosis, but I want to say there were areas that did have, by immunohistochemistry, some subtle melanoma in situ. But I often see cases that do not, because people will send them in to sarcoma or spindle cell experts when they don't have in situ, because those are the ones that are hard to recognize. I would also point out that spindle cell melanoma, whereas desmoplastic melanoma almost never has MART1 or HMB45 expression, spindle cell melanoma sometimes does, but not always. So the cellular spindle cell melanomas, they may sometimes show MART and HMB, but it tends to be more patchy, and I've seen many examples that were totally negative, and then people will often send those in and say, it's a malignant, looks like a sarcoma, S100 positive, therefore, I think it's malignant peripheral nerve sheath tumor. And I say, in the skin, on the scalp of an 80-year-old? No way. No, no, no. So that's a whole other lecture, and I've got like an hour-long video just about malignant peripheral nerve sheath tumor on YouTube. If you're having trouble sleeping at night, put that on. You'll be asleep in no time. MPNST, malignant peripheral nerve sheath tumor, the spindle cell conventional type, usually is either negative for S100 and SOX10 or has weak or patchy positivity. It paradoxically loses its normal neural immunophenotype when it turns malignant, which is surprising. Epithelioid malignant peripheral nerve sheath tumor is a different story. It will have strong S100 expression, but again, is a whole other topic for a different time. And even in patients with neurofibromatosis who have a tendency to develop malignant peripheral nerve sheath tumors, it almost never occurs in the skin unless it's coming from a deep soft tissue and pushing up. It has been reported, and I have seen, I think, one case of a primary small, what I thought had to be malignant peripheral nerve sheath tumor in the skin, but I would just almost never be willing to diagnose that on the sun-damaged head and neck of an old person. That is melanoma, 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 unless you can prove it to me otherwise. So that's just one caveat, and the reason I bring that up is I cannot count the number of times people have sent in cases convinced that it was a malignant peripheral nerve sheath tumor that was strongly S100 positive on the head and neck of an older adult, and it's always melanoma, okay? Please show additional cases. Fascinating presentation. Oh, thank you. Merci beaucoup. Is PRAME a useful tool for desmoplastic melanoma? My understanding from what I've read so far is that PRAME is not useful for desmoplastic melanoma most of the time, particularly for those ones that really look very neural and bland. So if you do PRAME and it's positive, well, that may be helpful. But I would expect that most of the time it will be negative, unfortunately. But maybe Arnaud can speak to that more. Have you found it helpful?
I do not find it helpful. It's usually very faintly or top-heavy.
Okay. I've only had the lab I work in now has PRAME, but my former lab did not. So I've only been using PRAME for about a year and a half. And desmoplastic melanomas are relatively uncommon. I only see them maybe a handful of times a year. So I don't have a lot of experience, but yeah, so far I've not seen one strongly positive.
A few comments.
Yes.
Another clue I used is the presence of mastocytes in a myxoid background that I saw in your slide. And also I have called the pattern for the fascicles, I call it the short staircase pattern.
Short staircase. Oh, I like that. It's like a little short staircase. I call them, I don't know if this joke will work in French, but I think they look like fascicles and nests, kind of a hybrid, so I call them nesticles. And my residents laugh, and so if it's memorable for you, But they look kind of like they want to be a nest and kind of like they want to be a fascicle. So nesticles, if you like. But I like short staircase. I'm going to start using that. That's great. By the way, I've loved your tweets and videos. Great stuff. I'm loving learning from you. This is wonderful. Oh, I'm curious. I'll ask you, Arnaud. When you have an area like this, do you consider it desmoplastic or spindle cell? Because I wonder, once it starts making packets, how much is enough? And I don't know if I ever have a good answer.
I have a very stringent definition for spindle cell melanoma. Usually I would have all this desmoplastic melanoma and not reserve the spindle cell for really fully
Very cellular.
Yes.
Okay, so you would have called the whole thing desmoplastic?
Yes.
Oh, okay, that's good to know. Maybe I've been too
Not see the
aggressive.
type of the area, but
Okay, that's good to know. All right. Thank you very much. That's very helpful. Well, to everybody online, we're back.
Yes, I think so.
Merci beaucoup for your patience. They gave me food and now cafe. I have the strength to keep going, I think. All right. Let's see where we're at here. It's not that. Oh, merci. 10. A 40-year-old man with a skin-colored skin nodule. That was a little redundant, I guess a typo. Skin-colored nodule on the flank. Now, Arnaud is here, and I was a little nervous since this is something that he basically is the world expert about. So I was like, oh, I got to study extra to make sure I don't say anything that's too wrong. And again, I told you, skin-colored nodule, right? So many things look like a skin-colored nodule. It doesn't matter what these cells are. They're going to look like a cyst or a lump, okay? The nodule is a circumscribed nodule down in the dermis. And that's a very interesting pattern when you go closer. It's made of spindle cells that are plump, geflus, right? Geflus is one of my favorite French words. I was giving a lecture in Quebec in Canada, and they were saying geflus, geflus. I was like, what is that? And they're like chubby. And I was like, oh, plump is the word that I use in English, but I like geflus. It sounds much more beautiful to my ear. So geflus. The cells that are spindled, but kind of have round to oval nuclei and more cytoplasm, right? Kind of a grayish cytoplasm, maybe a bit pale. And they have this very unique pattern where they're kind of like that spindled or desmoplastic melanoma we saw earlier, where you have the packets, kind of the cells are running in somewhat little short fascicles maybe, to small clusters or packets with collagen in between. Some of them have kind of prominent central nucleoli, many of them do, and many have, in this case, have pale nuclear chromatin. So by immunohistochemistry, these cells were positive for SOX10, S100, and patchy MART1, or Melan-A. To me, maybe Arnaud can clarify, but I think of MART1 and Melan-A as more or less the same thing. I think there may be a clone difference. So what do you do with a lesion like this that is staining melanocytic, has these cells that are, have prominent nucleoli, has this unique pattern of spindle cells in these little short nests or fascicles with collagen in between, is a circumscribed nodule, so that's not usual for many nevi, right? To have this like perfectly rounded nodule. One thing I would think about is clear cell sarcoma of soft tissue, which can sometimes present in the dermis or subcutis. But it's not quite right for that, but it does bear some resemblance. And this is a very unusual entity. This is, I think, the only example that I have seen of this, although I suspect there may be others out there, but the only one that I've recognized. And this is, I will pull up the paper to show you here. So this has been called several different names, but I think the current name that is being used by some authors at least is cutaneous melanocytic tumor with CRTC1 TRIM11 fusion. And at some point also melanocytoma with CRTC1 TRIM11 fusion has been suggested. I think it's an interesting tumor to know about. So far, very few cases have been reported. although I think that that will change in the future. There are more, I'm sure, that will be published. But a couple things that it makes me think of, it reminds me a little bit of clear cell sarcoma. It also reminds me a little bit of epithelioid schwannoma. So epithelioid schwannomas are a relatively rare subtype of schwannoma that have more plump epithelioid cells, and they have this kind of clustered, packeted kind of arrangement. Instead of verrucae bodies, the cells kind of curve together and make almost little nests that are surrounded by collagen. So I remember when I saw this case, this has now been published in the literature by my former colleague Sarah Shalin as part of this paper here. And so when I first saw it, she showed it to me, and I said, well, it kind of reminds me of epithelioid schwannoma maybe. And then also there's a tumor that was described long ago by my mentor Sharon Weiss as a paraganglioma-like dermal melanocytic tumor. Now, I have never seen a true paraganglioma in the skin, to my knowledge. I see them in soft tissue, but I have not seen one in the skin. So these tumors were described by them because of that kind of Zellballen, right, or nested appearance, as being a paraganglioma-like, and probably in retrospect, this tumor that they described probably falls under this category. I don't think those cases have been historically tested, although that would be cool to get those original cases from an archive and test them. So and then to rule out clear cell sarcoma, you can do FISH for EWSR1, the Ewing's gene, which is rearranged in essentially all cases of clear cell sarcoma. And the thought about these tumors is that they should have a good prognosis, very indolent, although there has been one case that has been discovered after it metastasized to the lung, and in retrospect with testing, it showed this same fusion. So it kind of called into question, is it potentially possible that these tumors could be a variant translocation, be actually clear cell sarcoma with a variant translocation? I don't know that I personally buy that idea, just because this tumor does look different to me than classic clear cell sarcoma. But it does at least raise the question of, will some of these with long-term follow-up show more aggressive behavior? And as clear cell sarcomas, you often have to follow them for many years to see how they behave, because they are not always rapidly aggressive. They are kind of aggressive, but over many years sometimes. So I think this is one of when Agnés invited me to do this, she said classic difficult cases and also new evolving entities. So this is one of the new entities recently described, something I only learned about in the past few years and still have only limited experience and knowledge about. So you can read some papers in here. One thing that I thought was interesting is that in some of the cases described, the tumors were diffusely positive for SOX10, but were negative or focal S100 or negative for other melanocytic markers. I'm curious to hear from Arnaud is that common? Because this case had S100, but is it common that they're S100 negative or weak?
It can be variable.
Variable.
For all the different patterns and types of...
So SOX10 is the best marker. Okay, so for those at home, Dr. de la Foucharière said that the markers can be variable. SOX10 seems to be the best one. And earlier you mentioned that they usually are NTRK positive?
It can be NTRK positive.
Okay, so pan-TRK, the marker for NTRK, NTRK, that marker is often positive in these tumors, or sometimes maybe. So I hope to see more of these in the future and more papers on this topic.
I've made a video of one.
Oh, they're on Arnaud's, on your YouTube channel?
Yes.
Yeah, so Arnaud de la Foucharière has a really awesome YouTube channel about complicated and unusual melanocytic lesions. So you can check that out and look. And if you have trouble finding it, if you look on my YouTube, I have a playlist called Other Pathology YouTube Channels. And as I find more pathology YouTube channels, I try to add them to that list so people can find them more easily. Because that's my goal, is that eventually there will be YouTube videos for all the different specialties freely available for the whole world. That would be amazing. Because people all the time say, oh, can you make a video about brain tumors or liver biopsies? And I'm like, no, I cannot. I only do skin and sarcoma. So I'm in no way qualified to talk about how to grade liver fibrosis and inflammation. Nope. But there are people out there who need to know those things. So I love finding more pathologists who are actively teaching online. And I'm really happy that I learn a lot from Arnaud, because he has experience with melanocytic tumors that I rarely or never see in my practice. And so I'm teaching you not as an expert in melanocytic lesions, but as someone who's in the trenches with you, fighting the war, trying to figure out every day, is this melanoma or not? Is the patient, do they need an excision? I don't know. So this is how I approach these cases. So you can read here. I've left some literature, which I believe are most, if not all, of the current publications on this topic. So you can do some more reading. And I should have left your video link in there, I guess. I will have to find it and tweet it. That's what I do. All right.
And what is the complementary treatment for this type of tumor? Is there a re-excision, or it depends on the case? Or
no one knows.
There is no.
The question from Agnés is, what's the proper treatment for these? And I think with many rare things, you don't know. I personally would think probably negative margins is a good idea, right? Yeah. I mean, that's kind of the approach for any uncertain malignant potential, or I think even newly described lesions where we think it's probably indolent, but there are so few cases we don't know. Yes. I think if it were on me or my wife or my daughters, which is kind of the gold standard I use, I think I would want a negative margin.
Because on this specimen, the margin are negative, but with 1 or 2 millimeter, but is it sufficient, or?
I can't remember. I can't remember. I can go back to the paper, but I want to say that this was re-excised, I believe.
Yes.
So, and I have seen a case since this one that I thought was either clear cell sarcoma or this, and we did testing for both, and it ended up being clear cell sarcoma. So there are similarities there, and probably some of the lesions that have been described as primary dermal melanoma, a nodule of melanoma in the dermis, which is a controversial idea, but probably some of those may fall under this category. Just in the past, people did not know about this fusion. So obviously, this is the new thing in pathology, right? More and more, I think we will find tumors that are defined by, or in some ways defined by their fusions. But I don't think it will totally take away the need for morphology, because as we've seen, molecular pathology answers some questions beautifully. But then it creates new ones where you have tumors that are totally different and yet have the same fusion. And they stain differently and behave differently. A good example would be clear cell sarcoma and angiomatoid fibrous histiocytoma. Completely different tumors, yet they can have the same fusion. How? I don't know. I don't understand it. Yes, Arnaud?
Also, there are some clinical relationship, because sometimes the patient, they complain about pain or tingling in the tumor, which is, I don't know any other melanocytic tumors that have some functional symptoms.
So Arnaud was saying that sometimes this entity has been reported as having neural kind of, pain or tingling, neuropathic type symptoms, but that's an unusual thing compared to most other melanocytic lesions would not have that presentation. So that maybe there's something unique about this. That's really fascinating. Thank you so much. The next one is a 20-year-old woman with a skin-colored wrist nodule, present for several years, and it's attached to the tendon sheath on imaging studies. No history of malignancy. So 20, a young patient. Now, that's a perfect section, right? I mean, a couple folds and a little scratch here. So what happens if you don't protect your unstained slides, little bits get scratched off. But overall, it's a perfect example here. So right down here, this dense band of pink, let's look at that before we look at the tumor. See how wavy that is? Wavy is not usually nerve. Everyone teaches nerve, wavy. Nerves are like gentle waves, maybe, slow and gentle. But when it's like this, ramen noodles or instant noodles, the little package of dry noodles that you take out when you're in college and you're poor and you can't eat. I don't know, at least in America we have them. I don't know, maybe not in France. You have them? What do you call, comment tu dis? Noodle. They're wavy, right? Really wavy when they're dried. And then you add the hot water and then they get soft. So one of my fellows, Dr. Ed Fulton, really awesome a fellow of mine in the past, a trainee in dermatopathology, he said, you know, it looks like ramen noodles in the package, how wavy. When it's that wavy, it's usually not nerve. It's usually collagen, dense, regular connective tissue. And that type of tissue encompasses tendon, ligament, fascia, and a lot of things that are fibroblastic lesions that have a background of collagen. What happens is during processing, the tissue shrinks up. And in the fibers that are normally stretched out, they become very, very wavy. So the only reason I belabor this point is that I have encountered not just trainees, but practicing pathologists many times that have struggled to identify that this is not nerve. This is fascia or tendon sheath, dense, regular connective tissue. It can make a very big difference. For the example here, the reason we need to know is that we know that this tumor is down deep enough that it's sitting on the tendon sheath or the fascia and directly adherent to it, attached to the collagen of the tendon sheath. Now, basic histology is always so important. Even now, all the time, one little tiny finding of histology sometimes will make a difference between recognizing that something's not a little bit of melanoma in a lymph node. So I really think you can never spend enough time learning all the subtleties of basic morphology for normal histologic structures. So here, this tumor is a nodule, kind of multinodular. It's very pale from low power. And as we go closer, you can see a lot of the cells truly have clear cytoplasm. All right? In other areas, the cytoplasm is not truly clear, but kind of pale, like here. Kind of pale gray or pale eosinophilic. So it can run a range as far as how clear the cytoplasm is. I think the most classic areas are down here, where the cells are arranged in, again, these kind of nest/fascicle overlap. Okay. They're these, if you cut them longitudinally, they look like long fascicles of plump spindle cells, joufflus, right? Oh, sorry. If you cut them in cross-section, they look more like nests. So it is a matter of three-dimensionally if it's cut long or across. The cells are relatively uniform. Their nuclei are oval and all look like each other, okay? That is a general feature of most translocation-associated neoplasms, particularly in soft tissue pathology. If there is a balanced rearrangement or a gene fusion, usually the tumor will have nuclei that all look alike because they all have the same molecular event that's driving the tumor. Pleomorphism oftentimes is a marker of underlying chromosomal instability or aneuploidy, random chromosomal gains and losses. This is not a perfect rule, but it works pretty well because if you think about all of the translocation sarcomas, synovial sarcoma, Ewing sarcoma, clear cell sarcoma, which is what we have here, and more. They may have mitoses or necrosis, but you don't see pleomorphism usually. Now this tumor, when it recurs or metastasizes, can sometimes get pleomorphic, but usually it does not. And it's a really great rule, solitary fibrous tumor, translocation associated. It's a really great pearl that one of my mentors, Dr. Mark Edgar, taught to me. And he taught me a lot of really great visual tricks and tips in soft tissue pathology that I now pass on to everyone whenever I speak. So the cells are uniform. They do tend to have prominent nucleoli. See the nucleolus there? I'll show you a better area in a minute. Oh, there. Nice nucleolus. Almost that cherry red nucleolus, like the nucleolus of a melanoma, a little bit. The other thing is that in between the nests there is dense collagen, dense pink collagen, dividing these nests or fascicles like this, okay? So these features are characteristically seen in clear cell sarcoma, which has also been called in the past, much to the confusion of many, melanoma of soft parts. We now know these are not melanoma in the traditional sense. They are separate and distinct. And this was first described, or at least the landmark paper describing them was by, I kind of think as my academic grand-père, Franz Enzinger, he trained Sharon Weiss. Sharon Weiss trained me, so he's like my grandfather. He would probably not have, I never met him, unfortunately. He died before I was a pathologist, but he, not only this, but he described many of the main entities in soft tissue pathology, really an amazing legend. And it's really great to be able to see these tumors that he characterized in the 1970s and 80s with no molecular or anything, just morphology. Those days, wow, amazing. So that pattern right there is what should make you think of clear cell sarcoma. So a few things. One other thing that's, let me see if I can find it. I should. There's another feature you often find in clear cell sarcoma. Oh, look at the nuclei there. Very big. And look, the nuclei look round, not oval, because again, it depends if you cut them long or cut them across. The nuclei look different, whether they're elongated or round, right? So, oh, sorry, I don't know why these keep, okay. So that is a good, and then in here, there should be a multinucleated giant cell. I thought I had it. It's right. I've looked at this slide enough times. I should have it memorized, but I get lost. Oh, come on. Dusicle.
We have time.
We have time. Okay, good, good. It is embarrassing. I should have. Oh, maybe I did take a picture. Hold on. Ah. That is not a Teuton cell. That is not a histiocyte. It is a tumor giant cell. The nuclei here look the same as all the other nuclei. They are just fused together to make a ring-shaped, kind of halo-like multinucleated giant cell. It's a common feature in clear cell sarcoma. So these tumors, the reason the name melanoma of soft parts or of soft tissue came about is that they do have some similar cytology as melanoma, the big nucleoli. They have a very similar immunophenotype. They stain with S100 and SOX10 and MART1 and HMB45. And I just learned today from Arnaud that they are positive for NTRK, right? The pan-TRK marker, which is cool, and I didn't know, and I'm going to have to try that out in my lab next time I see one. Oh, whoops. That's not a slide, that's a PowerPoint. Okay. There. So when they have classic morphology like this, great, clear cell sarcoma. You see it, you've done immunostains, it stains like melanoma, and then you recognize by the morphology, this must be clear cell sarcoma, and you do FISH or RT-PCR to show the fusion, which is EWSR1, the Ewing's gene, with ATF1 in most cases, and there is a rare variant fusion also. The problem is that if it doesn't have classic features, if it looks like maybe this, but then you might struggle, because when I look at a picture of that, I don't instantly think clear cell sarcoma. I would scratch my head and think of a variety of different things. I mean, there are areas here that vaguely remind me of the CRTC, vaguely. Arnaud's probably shaking his head like, no, surely not. But I mean, I don't know, I might think of melanoma. I mean, it's pretty solid. It's not truly clear. It's kind of gray cytoplasm. Yeah, there are some nucleoli, but they don't instantly give me the classic feeling of a clear cell sarcoma. So one thing I recommend is if you had say you had a nodule of melanoma in the deep dermis or subcutis, if you see a nodule of melanoma down deep, that is metastasis until proven otherwise, right? When we see a nodule that's deep dermis or subcutis, that is the way that metastatic melanoma presents. So if I see something that I think is a nodule of melanoma that looks like maybe it'd be a metastasis and it's on the extremity of a young person who has no history of melanoma, well, is it possible? Yes. Melanoma we see present as metastasis with no known primary. On a regular basis, I've seen that. But in a young person on the extremity, that would be rare, okay? So in those cases, I stop and think, could it be clear cell sarcoma? And if I have any doubt, then I do the molecular, because it probably does make some difference for treatment. Say you want to excise these with negative margins, And if it's a metastatic melanoma, usually they will still excise it, but the margin status is not quite as important because it's already stage 3 or stage 4. The other difference now is that in the age of targeted therapies and checkpoint inhibitor drugs, which are very expensive, at least in the United States, and they're drugs that come with a significant potential side effect profile. The potential maybe to cure or turn metastatic melanoma sometimes into a chronic disease, or maybe even cure it, but at the risk of very severe side effects. And I had a relative actually who unfortunately died from metastatic melanoma and took checkpoint inhibitors and really had a lot of side effects, really bad ones from it. So they're amazing, miraculous drugs, but they also at the same time, when you unhook the immune system and let it go unrestrained, it comes with bad side effects. My understanding is that people have tried checkpoint inhibitors, some with clear cell sarcoma, but I don't know if there's been proven success because these are very rare. I only see these maybe once every 2 years or so. Very, very rare tumors. But I always try to think of them if I'm thinking of a metastatic melanoma, particularly in the extremity of a young person with no history, okay? So it's good to know about. You can test for it with molecular. And unfortunately, the 5-year survival is pretty decent. But if you follow patients 10, 15 years or beyond, the prognosis becomes much, much worse. They tend to recur, metastasize to regional lymph nodes, and eventually have distant metastases, which is very unfortunate. So, and they often affect young people, young adults. So it makes it even more tragic. Terrible disease, but one that's good to know about. And I think this is, to me, a very characteristic example of clear cell sarcoma. Anna, would you have any comments you'd like to add? I would love to hear your viewpoints. This is great. I get to attend the session and be taught.
So,
now I feel bad. I put him on the spot.
So regarding the case that was metastatic, did not have a proven intradermal primary.
Okay.
So one of the hypotheses I put in my initial paper is that maybe like leiomyosarcomas, they could be encased in the dermis, and that will prevent the dissemination to other parts of the body. So
the idea for the CRTC1
yes,
trim 11?
and I know that also this is a deep, soft tissue.
Yes.
Side, but we know that the skin ones that are rare, they tend to perform less poorly than these deep tendon lesions.
So Dr. de la Fouchaudière said that one idea going back to the CRTC1 trim 11 is that maybe they are better because they're small and superficial, and that being intradermal gives a prognostic benefit, right? We know that some diseases that would be bad when they're deep, like leiomyosarcomas, behave much, much better when they're confined to the dermis or superficial soft tissues. That's true of pleomorphic liposarcoma, a very bad tumor in deep soft tissue, approximately 50% 5-year survival. But when it's in the skin or subcutaneous, the vast majority of patients essentially survive and do fine. So some tumors are much better when superficial. Now that doesn't apply to all. Rhabdomyosarcomas in the skin, still terrible disease and metastasize and act aggressively. So there are some clear cell sarcomas. This is the classic where they arise off of the tendons or aponeuroses, but some of them present as intradermal, and Arnaud was saying that those have been reported to have better prognosis. So that's really interesting. Thank you. All right. Let's see what's next. We have a 16-year-old boy with a skin-colored papule on the scalp. So you can see a nice punch here that has really gone right around the lesion. It does go focally to the edge, but they got the majority of the lesion. Let me show you this one first. And going in closer, there's two different things here, okay? Number one is what's happening at the periphery, and the second thing is what's going on in the middle. So let me show you the edges first. This looks like, to me, a regular conventional nevus, maybe congenital type, right? Small nevoid melanocytes that are kind of trickling as they go down deeper. There's more over here. So to me, a regular benign nevus that I would see any day. But in the middle, we have a more cellular nodule. And it's composed of cells that are much larger. They have round nuclei that are bigger. Some of them there's some scattered pleomorphic cells. Not diffuse pleomorphism, but there are scattered large cells. The cells have abundant cytoplasm, and many of them, as single or maybe double cells, are wrapped around by a little layer of collagen. They're kind of encased in their own little cocoon of collagen. So, and the cells are much more cellular in the middle. Looking around, though, mitotic activity, to my recollection, was very low for this case. So when we see a lesion that has looks like a nevus, but has two different components, one thing to think of is a combined nevus or a combined melanocytic lesion, where you have two different patterns of nevus or melanocytic proliferation arising in the same area. The other thing that I always worry about is, could it be melanoma growing out of a background nevus, a melanoma arising in a nevus? So to me, that's always my concern. This was a young patient, a teenage patient, possible to have melanoma at that age, but very rare, I think, overall. The other thing, somewhat reassuring, is nothing in the epidermis that looks like melanoma. Now, that's not perfect, right? We do know that you can sometimes have melanoma without an obvious in situ component, but that's one thing that I think about is, do I see anything in the epidermis that makes me concerned? Pagetoid spread, confluent growth, things like that. So I had an idea here, and I did a stain. And I will show you. Oh, there's more of the cytology. And here. And what stain is this? Does anyone know? Yeah, BAP1, BRCA-associated protein 1, BAP1. So this is something that I think Dr. Wiesner was one of the first to start writing about this, and others have. And the idea of these is that these are lesions that have loss of nuclear BAP1 staining. So BAP1 is present in many of the nuclei of normal cells in the body, including the nuclei of normal conventional nevi. But in these lesions, you have a component of the lesion. Usually there's a background regular nevus, and then a zone of larger, more epithelioid cells that have loss of BAP1 staining. And you can see real clearly here that the nevus, the conventional nevus at the edges, retains the nuclear staining, and these cells in the middle, it's lost very cleanly, right? As with any immunostain where being negative is meaningful, right? Most immunostains are, when they're brown, they're positive. But a stain where it's lost, you have to be very careful to make sure your internal control works, right? Just like the microsatellite instability stains, or INI1, SMARCB1, or BAP1. You have to make sure your internal control stained well. So here, those are the nevus cells, and then here is the central area, okay? So these have been called by a variety of names. The name I kind of like, even though it's not official or proper, is BAPoma. It's the BAP tumor, right? And I know it's not proper. And look, Arnaud is like, he's weeping in the corner there. But when I talk about them to my colleagues, I say BAPoma. Everyone understands what we mean. Now, I don't call it that in my report. But I actually have struggled a little bit with what do I call these in a report, because the literature has used a variety of different names over time for these, okay? So the question, first of all, is, well, what are they? So what happens here is that, and again, I think the WHO book has a very nice explanation of the general molecular ideas behind nevi and melanocytic neoplasms. And I've also given you some references here that talk about this entity. But the idea is that, regular nevi usually have an inciting mutation that causes them. And in this case, in these lesions, usually it's a BRAF, V600E, I think is the most common mutation that causes the regular nevus that's in the background. And then a second phenomenon happens where BAP1 is lost in this central proliferating kind of area of more enlarged epithelioid cells. And this can happen in two settings. It can be sporadically in normal individuals, in which they've had knockout of both copies of the BAP1 gene, the one on both of their chromosomes. But there are also people that have loss of BAP1 as a germline abnormality, where they are missing one copy of BAP1. And in those patients, they only require one hit to knock out BAP, okay? The reason that's important to know is that patients that have germline BAP1 abnormality are at risk for a variety of different tumors. Uveal melanomas, they're at risk for mesotheliomas potentially, and others, right? So we know it's basically a cancer-associated syndrome related to BAP1. So this lesion potentially serves as a marker of patients with those syndromes. And my understanding is that when you see these, about 10 or 15% of them are going to be associated with the syndrome, but the majority are just incidental, sporadic lesions in otherwise normal individuals. And pretty much all the data that I've read on it, these are going to probably behave in a benign fashion, although it is possible to have melanomas with loss of BAP1. All the ones that I've seen so far, to my knowledge, behaved well. I still have recommended complete excision with negative margins, and I've recommended the patients see a genetic counselor to discuss the pros and cons of germline testing for BAP1. My understanding is that the patients that have the syndrome, the germline BAP1 loss, they often get multiple lesions that look like this. So I also think of that because some people have pointed out that these have a somewhat spitzoid appearance. Molecularly, they are not spitz nevi. But some people early on had suggested they look kind of like spitz nevi. I think the nuclei are different, but the fact that they are large, plump cells with abundant cytoplasm, I think does call to mind or resemble to some extent, superficially resembles spitz nevis. And so whenever I hear a person with a history of multiple atypical spitz nevi, I instantly stop and think, I wonder if they really have a BAP1 loss lesion. Because it's been around maybe 10 years or so, but I think it's still not widely recognized outside of dermatopathology. And so many lesions probably that have been classified in the past as an atypical spitzoid lesion may have been these. And yet maybe at the time people were unaware of the diagnosis. So this patient thankfully had genetic counseling, and germline testing was negative. This was just a incidental lesion, and as far as I know, had an excision with negative margins, and follow-up has been good so far. So I had the pleasure to get to meet with the family of this patient and talk with them about it, and it was a really great experience to do that. So be on the lookout when you see this large nodule. In this case, I was a little concerned, even though I saw the BAP1 loss. I wasn't sure, like, what do I do about these big nuclei? Is this too much? Do I need to worry? And I sent it off for consultation to melanocytic experts, and they said, no, this is BAP1 nevus or melanocytoma. So that's the next thing we'll talk about. And again, I told you the afternoon was going to get harder. You have that postprandial somnolence, right, from eating the lunch. And then I'm talking about all this esoteric, rare, confusing stuff that I still struggle with. So this is how I feel in the afternoon. Usually these cases, I say, tomorrow, demain, in the morning. But today we have to do it in the afternoon, okay? If I would have done it this morning, though, you would not have come back after lunch. You would have gone home. So I had to trick you and lull you into, this is good. And now you're back. Doors are locked. I'm not going anywhere. Good crowd. Thank you for the laughs. It gives me some energy. So I wondered, in the WHO, it talks about that it includes this category under the combined nevus or melanocytoma category. So what is a melanocytoma? Well, I like the WHO has said it one way, and I also, my friends at UCSF, University of California, San Francisco, they had a little comment in their report that says, that melanocytoma basically is a lesion that has more abnormality, particularly genetic abnormality, than a regular nevus, but it doesn't have features sufficient to make a diagnosis of melanoma. So it's kind of in the gray zone. And I kind of like it because it standardizes the terminology we use for these lesions that don't fit neatly into benign or malignant. In the old days, some people said, well, there's no such thing as gray lesions, only gray pathologists, right? That you should be black and white, and it's not the lesion's problem, it's your problem. But I don't believe that, and I think molecular is proving that that's maybe not true. We make boxes because it's so comfortable and convenient, isn't it? When I take it and I drop that tumor right into the box and it fits perfectly, well, it doesn't always do that. The tumors don't read the textbooks that we make for them, right? They do what they want. And we have to find a way to deal with the ones that don't fit in the boxes. And it's a struggle for me all the time. So the WHO, for all the things I like about it, I didn't feel like reading the chapter on this gives a clear answer of when to call it nevus and when to call it melanocytoma. They kind of say nevus/melanocytoma. So I've struggled with this, and I wonder, like, well, and I'm really curious to hear how your approach is. But when I sent this off, it came back from the experts as BAP1 inactivated nevus, open parentheses, BAP1 inactivated melanocytoma. So even the experts, I think, struggle maybe of where exactly to put these. I usually say nevus/melanocytoma, say that the prognosis is probably very good, but that you should excise it with negative margins. And I've not yet seen one that was frankly malignant, but I am really curious to hear input from a true expert here, because I am just a novice trying my best to make it through each day. So, Dr. de la Fouchaudière, would you can come up here, come to the proper mic. And I was very nervous when, and then I was tweeting about coming here, and Arnaud's like, oh, I'll come. And I was like, oh gosh, I've got a couple entities that are like his thing. So I usually talk about soft tissue because I know about soft tissue tumors usually more than most people in the audience. But when you have an expert in the audience, is the nerves a little bit more.
So
please teach me.
What you would start with the melanocytoma. So you have to understand that in the concept of the WHO, melanocytoma is just a category that is between the progression model from nevus to melanoma, and we put two intermediate steps. So in the BAP1 group, the first step would be just the BRAF mutated nevus. And then the second step, which is a low-grade melanocytoma, is the BAP1 inactivated nevus. This is a perfect example. And what you have, low mitotic activity, and usually I use proliferation rate is under 5%. And also you see there's no hyperdensity. And for me, the main differential is I agree, nevoid melanoma ex nevus. So that's what you want to rule out. And then the third step is the high-grade melanocytoma. And these these are rare. And I have cases that go to, I have seen more than 20 cases that go to melanoma. And what is interesting is like, I have really the luck to find cases that have on the same slide the 4 different stages for BAP1 or for DPN, and I've shown this, and I should make videos.
I was going to say, I want this video.
So, and you really see the progression from the nevus, the typical, the low-grade melanocytoma, the high-grade, which gets higher density and less cytoplasm and more nuclear atypia. And then you see the really malignant with the mitotic activity, and you even see it on the CGH with the clonal. So this is the clonal disease. Okay. So what else was?
Yeah, so you have seen some where they are progressing all the way to malignancy.
And to become metastatic. So
wow.
But I know there are very few reports, and this is a paper I should be writing. I have more than 300 cases of BAP1 inactivated tumors, and among them are.
See, I told you.
more than 20 are really malignant cases, and some are metastatic.
I think I've seen 10, maybe. In a decade. So yeah, but that's awesome. Thank you so much. This is the ultimate crowdsourcing here. I was like, oh, I'll make him give the lecture. And that worked out pretty well. I learned. Thank you very much. I truly appreciate that. Merci beaucoup. I would love to see that video, actually. That would be amazing. Because I think this is something, as you read the literature, there is still, I think, confusion is not clear or widely understood clearly by regular folks like me trying to diagnose, like how to approach these, when to worry. Do you routinely recommend genetic counseling or germline testing?
Yes.
Okay.
Systematically. And I mostly recommend if the patient had another dermal nevi removed, to have it tested by IG.
So Arnaud said that he routinely does recommend for the patients to have genetic counseling or genetic testing to see if they have germline BAP1 abnormality, and also that if they've had other nevi removed, even if they were just called regular nevus, maybe to consider doing BAP1 immunostain to see if there was loss in those lesions. Because it would be, if they have more than one lesion with BAP1 loss, then they almost certainly are germline, right? Okay. Really, really amazing. So so these are things to be on the lookout for, because they look really scary and a lot of complicated issues to deal with. And do you have genetic counselors in France? Is it a field here?
Yes.
So I really like it, to go on a side note, in general, when dealing with complicated molecular syndromic type abnormalities, I love recommending patients to see, not just have the test done, but see a genetic counselor, because there's a lot of complicated issues that go into molecular testing, especially when you're testing for something germline, because you're not just testing that patient. Your test applies to their kids. And whether or not, if they're young, if they decide to have children, family planning, there are a lot of issues that become very important ethical issues. If the person's a child, do they really understand the implications of having that knowledge about their own molecular abnormality and what that might mean for their future decisions? I may think I know what I would want to do if it were me, but I don't necessarily know other people's values or how they will do it. So I feel like genetic counselors deal with that complicated discussion on a daily basis. And I think it's important as pathologists, we understand that you have to understand what question you're asking when you do a test. And you also have to understand what you're going to do with the answer to that question. If you just do a test and you're like, oh, well, now it's positive, now what? That's a problem. So I think that having these discussions ahead of time helps to avoid those complications. And I've routinely I had a genetic counselor call me up a while ago and say, I saw that you recommended a referral to genetic counseling in your path report. I've never seen that before. That's really cool. And I was like, you guys are doing amazing stuff. And it really, I think, makes a really important contribution to patient care. Because again, we get focused a lot of times on metastasis and death from disease. But there's a lot that has to do with anxiety and patients worrying every day. Am I going to be alive to take care of my kids in a few years? Are my kids going to get this tumor that I have? I work with these rare cancer groups. That's what these people worry about. They worry about what their next scan will show, or will my child get dermatofibrosarcoma, or which of course, no, they won't, because it's not germline. But they just understand DNA problem, right? So I think there's a huge problem with lack of knowledge and education of patients. And having seen the suffering mentally and emotionally that some of these patients go through, information is a simple, free way for us to fix some of that problem. It doesn't fix everything. So I feel like as pathologists, we can be the gatekeepers there, and we can see that there's a problem ahead of time and recommend those patients get to the proper treating doctor, the proper team to take care of them. Same for like neurofibromatosis. They need someone who pulls all the info together, and neurofibromatosis involves lots of different organ systems. I think genetic counselors play an important role there too, because it's such a complicated disease. Arnaud.
I worked with the counselors to write how to write it in my report.
Oh.
They helped me. So it was together that we worked the way to make a formula that would fit everyone.
So Arnaud is just saying, oh, it's beautiful. It's amazing. He said he worked with the genetic counselors to come up with the proper language to use in the comment of his report that is the best approach and the best comment that helps everybody. I would love, if you're willing to share, I would love to get a copy of that and see how you word it. You know, a true master of BAPoma, if you'll forgive my very slang street name. Okay. Well, anyway, thank you for indulging me. But it's a topic I feel very passionately about, and I think pathologists, we're often looked at as people that just do autopsies or hang out in the laboratory, but we actually have an enormously important role to play in patient care. And sometimes we're the last line to stand up and help avoid a problem from happening to a patient. And if we can do that, I can say I've done my good deed for the day, and I can go home and sleep well that night. All right.
There was a question.
Oh, a question? Yes.
If the patient was older,
Would you? Oh, I don't know. So I'll let Arnaud. If the patient was older, would you perform the BAP1 stain or think of nevoid melanoma?
It can start in children, but you can have it at 80-year-old.
Oh, okay. So it can happen at any age, so still worth doing even in older patients. Yeah, and I think with genetic things, I know it is often more problematic for young people, but if in older adults maybe already have children or grandchildren, there are times where germline things, may be meaningful for other living relatives to know about potentially.
And also, there's almost a systematic pattern of P16 expression in the inactivated tumors. And in lymphoid melanoma, it can be completely lost or clonally lost. And you never almost find it in the BAP1 inactivated nevus.
So you see P16, what does it look like?
Would basically exclude a diagnosis of BAP1 inactivated nevus.
So do you see patchy P16 or is diffusely positive?
No, it's heterogeneous but stronger than in the background.
Oh, than the background nevus.
Yes.
Okay, so I know this is now Arnaud's lecture here. We'll have to, no, please don't. I'm apologizing for my lack of knowledge. You guys have me here as the expert speaker, and I'm like, well, it's good for us to know there's always people that know more than what we know. And I've learned a lot. This is wonderful. So he was saying that you will see a subset of the cells will stain in the BAP1 lost area. It will be some positive, some negative, heterogeneous, but stronger intensity than in the background nevus and not diffuse loss, right? Diffuse loss is a strong argument against a BAP1 inactivated nevus or melanocytoma. Wonderful, thank you very much. Yes?
The both cells expressed in the segment, the melanocytic markers?
I don't know. Do they both express melanocytic markers the same way, like MART1, SOX10? I don't know if I've done it before. I don't remember. Because usually when I see it, if I recognize it, I think, oh, BAP1, and then do that. Occasionally, I guess I've done other markers, but I don't remember ever seeing a difference in MART1.
MART1, it can be maybe weaker than in the background.
It could be weaker MART1 in the BAP1 loss?
It's rare to have, it can have focal HMB45.
Focal HMB45. Okay, cool, great question. Well, I just went to school. All right, thank you. That was really great. I learned a lot. So this is a subcutaneous back mass, 12 centimeters, in a middle-aged woman. MDM2 amplification by FISH was negative. And here's what we have. So clearly, this is a large tumor, right? We have multiple pieces, representing different samples from different areas of the tumor. And you can see it's pretty heterogeneous. You have areas like this that are clearly mature fat with a lot of dense collagen, very sclerotic collagen. Areas like this are less fatty and appear to be more spindled, maybe more myxoid. There's something in there that's replacing the fat. I'll show you a few others from low power, just to show the heterogeneity of this tumor. That one didn't, there we go. So it really can run a range morphologically. Okay, so let's go in higher power. Well, the first thought I might have is I see mature fat of variable size, small, medium, and large adipocytes, dense sclerotic collagen, and large hyperchromatic pleomorphic cells. I mean, to me, that looks like well-differentiated liposarcoma, right? But I already told you MDM2 is negative by FISH, and the vast majority of well-differentiated liposarcomas are MDM2 amplified, with the very rarest of exceptions. So that is, I think, the most important thing to rule out is well-differentiated liposarcoma. Now, we won't go deeply into liposarcoma, but I do have like an hour-and-a-half long video of liposarcoma 101. So if you really need to know, that's your video. If you want to go to sleep, that also might be a place for you to start. But anyway, it's on YouTube. It's got like 100 and some pictures. So if you're like trying to picture match, can a liposarcoma look like this? Go check it out. The name that we give for well-differentiated liposarcoma when it arises in the superficial soft tissues or when it arises anywhere on the extremities, we call it atypical lipomatous tumor, ALT. So well-differentiated liposarcoma and and atypical lipomatous tumor are the same thing. We just give a different name because of location, because there's a difference in prognosis. In the superficial soft tissues or in the extremities, the behavior is excellent, the prognosis is very good, and usually they're cured by surgery. In the retroperitoneum, those tumors usually recur again and again, and over many years, the patients have a significant risk of dying from their disease eventually. But that's not what this tumor is, but it is important to be familiar with that tumor because it's the most important mimic to rule out here. But this tumor has areas that look like that, but as we look around, the other areas have some different findings. For one, look at these collagen bundles. The collagen in well-differentiated liposarcoma is usually very homogeneous, dense, sclerotic collagen. But here we have these thick bundles, rope-like bundles, right? Similar to the collagen that you see in spindle cell and pleomorphic lipoma. In spindle cell lipoma and pleomorphic lipoma, we recognize they are the same tumor. We just give them different names because of their morphology, but they are on a morphologic spectrum. They have the same behavior and the same molecular abnormality, which is loss of or deletion of 13q, chromosome 13q, which is where the retinoblastoma gene resides, RB1. So by immunostaining, usually the majority of spindle cell and pleomorphic lipoma have loss of nuclear RB1, or you can do FISH to show monosomy, deletion of one copy. So in these areas, this really looks like pleomorphic lipoma. You have the ropey collagen bundles, mature fat, and the cells, even though they are very hyperchromatic and pleomorphic, look at the shape. They are wreath-like or floret-like ring of atypical hyperchromatic nuclei. That is the very typical or the very classic feature of pleomorphic lipoma. So why don't we just call this pleomorphic lipoma? Well, in the past, that's what I would have done. And in my training, that's what we did. We saw big things that looked like this, very ugly. We just called them pleomorphic lipoma. Yes, it's 12 centimeters, but MDM2 is negative. It's pleomorphic lipoma. But some people have come up with the idea that maybe these tumors deserve a different name. And so one of the name that's been proposed for this tumor is atypical pleomorphic lipomatous tumor. Now, you may not like that name, and I did not write the papers, and the people who wrote it are very good, excellent people, and I love their work and respect it. I do think the name is confusing, as are many names in soft tissue pathology. If you find them frustrating, you're not alone. They are confusing because they all sound alike. If you take lipo, mixo, fibro, and oma, and maybe put the word atypical in, and then mix and match in different ways, and then it's that soft tissue pathology right there. It's much like French, right? Je veux, tu veux, il veut. They're spelled different, they sound the same. C'est très difficile. All right. Okay. So to me, the authors who have proposed this terminology, some of them have suggested that these are different than pleomorphic and spindle cell lipoma, whereas others have recognized that maybe they exist on a spectrum. I personally believe these truly are the same thing. They have loss of RB1. They behave in a benign fashion, maybe rarely can recur, but they do not metastasize. And as far as we know, they have no risk of de-differentiating into high-grade sarcoma. So the key to me is just to recognize whatever name you call this, this is basically the upper end of the spectrum of atypia and size that you can see in pleomorphic lipoma. And on a similar note, you can have ones that are spindled and look like spindle cell lipoma without the pleomorphic floret cells, but are very large. They can have mitoses, sometimes even atypical mitoses. They can have lipoblasts. So I understand why people use a different name because they look like really, really scary pleomorphic or spindle cell lipoma. But to me, they are more or less the same thing. Probably on these larger ones, I think excising them with the negative margin may be a good idea. But otherwise, for regular spindle cell and pleomorphic lipoma, I tell the surgeons, these are benign. You don't need to do anything else. Simple excision is curative. On these big ones, if they're scary enough that I use the name, then I tell them excise, but it's going to be okay. But in any case, that is what this entity has been proposed as, and it is included in the new 5th edition WHO soft tissue tumor book, which is why I want to make you aware of it. So in any case, that is what we're dealing with here. And I think it's good to know that you can have pleomorphic lipoma that or what atypical pleomorphic lipomatous tumor, that is this atypical. So I don't use that terminology often, but I have used it a few times. And this was one, because this was, I think, one of the first ones I saw that I thought, whoa, maybe it's a reasonable name, because it looks very much like well-differentiated liposarcoma in some areas. So I find the RB1 immunostain to be really helpful for these. It's usually going to show loss of staining in those large pleomorphic nuclei. It can be a little bit of a finicky stain to get to work. You need to make sure that your lab optimizes it so that the background cells stain nicely to be able to tell that there's true loss. And in my experience, both for these and for spindle cell and pleomorphic lipoma, the loss is not 100%. It's particularly the large cells, the majority of the large cells or the lesional spindle cells will have loss. And you'll see staining in the background blood vessels, okay? And my personal preference for MDM2 testing is to use FISH. Some people like to use the immunostain, and that's okay. But do recognize that the immunostain is not perfect. It can stain histiocyte nuclei, particularly when there are histiocytes in areas of fat necrosis, as often happen in many different fatty tumors. And so you can get false positive staining. So I think if you have MDM2 immunostain in your lab, but not FISH, it's reasonable to use the MDM2 as a screening test. If it's totally negative, that's reassuring. But if it's positive, I would personally prefer to proceed to FISH. I'm lucky that I have MDM2 FISH in my laboratory, and so I just go straight to FISH personally. And when I was in training, we did not have the immunostain, we just had FISH. So all I've ever really known is FISH. But I have seen multiple consult cases that had MDM2 positive staining in tumors that were not well-differentiated liposarcoma, and that has made me quite hesitant to use the stain. So, but I know some very good soft tissue pathologists like Dr. Elizabeth Montgomery. We wrote a book together, and she said she really likes using the stain. So not everyone has the same view as me in that way. And like spindle cell and pleomorphic lipoma, you'll often find CD34 expression in this tumor, and you can sometimes see a little bit of desmin expression too. Because remember, myofibroblastoma, mammary myofibroblastoma, is related to spindle cell and pleomorphic lipoma and has a lot of desmin expression. So sometimes you'll see some desmin expression in spindle cell and pleomorphic lipoma. Okay?
You can be helped with the immunohistochemistry with HMGA2 because it's often positive in lipoma and atypical adipocytic tumor, and it's negative in pleomorphic lipoma or atypical pleomorphic lipoma.
Okay.
And it's not positive in the histiocyte, and effectively MDM2 can be falsely positive in the histiocyte, but not HMGA2.
So Agnés just told me something really interesting.
It's a very French use.
Yeah. French use. Yes. I like that. You can sell it on that. If you say this is the French way, then people say, oh, we are getting that in our lab now.
And moreover,
you should write a paper. That would be awesome.
It's a use that I learned with Jean-Michel.
With Jean-Michel.
And not everybody in French use it.
Okay.
But I use it.
So I'm going to repeat your comments. So Agnés Neuville said that one stain that if you have it available, you could consider using is HMGA2, which is positive usually in lipomas and well-differentiated liposarcoma, but is negative in spindle cell and pleomorphic lipoma and presumably in this atypical end of that spectrum, and that it does not have the problems of staining of histiocytes in fat necrosis. So to my knowledge, I don't think we have that in my lab, but that sounds really cool, and I would like to try it out now.
Because the immunohistochemistry for IBA1 is sometimes difficult to interpret, and I use for that HMG2.
That's awesome. This is I'm learning so much. The French method too. I like that. The French lipomatous tumor approach. Well, Jean-Michel Condra is obviously a legend in soft tissue pathology, and like Agnés said, we met at a meal where Dr. Weiss and Dr. Condra went for dinner, and we were lucky enough tag along with the greats, and what an amazing experience. And Sharon Weiss, who I look up to with the greatest of respect, always spoke with glowing terms about Jean-Michel. And I thought, well, if Dr. Weiss thinks he's good, he must be really good. And everything I've ever known of him or read from him has proven that to be the case. So that's when I learned early on, the French know what they're doing when it comes to pathology, right? Very good. Any questions about this tumor? I wish we did a better job with naming things in soft tissue pathology. It's very confusing, especially when we have to explain this to surgeons and treating doctors. It's hard enough for us to understand our own terminology and then to tell people, well, I know this sounds like a fake, made-up name that I just invented descriptively, but it's actually a proper name. And so I think I have a sample pathology report in the handout that you can see some ways that the language I've used. And my goal is eventually I have thousands of these saved from over the years. My goal is eventually to release all of them onto the internet so people can use them and save some time in the way that I spent all this time thinking, typing, deleting, and then after 30 minutes of time, I'm like, there's the report. It's like 3 sentences long. And then I'm like, and then you just feel so like demoralized. Like I should be better by now. I can't believe I wasted 30 minutes. So I'm like, I'm going to get my time back. I'll save that and I'll put it on Twitter or on the internet somewhere so someone else can save some time in their day. So let me help you with that time I've already used up. Okay. The next one is subcutaneous mass on the thigh of a middle-aged adult woman. This is a fun case, but another one with the naming problem. So here you've got a nodule in the dermis and pushing into the subcutis, relatively small. It looks like this is almost completely kind of pulled out, shelled out from the skin. From low power, you can see there are some cellular zones here, some less cellular, maybe pale myxoid areas. And as we go into higher power, the most striking thing about this tumor is look at the blood vessels. That's crazy amount of blood vessels, so many blood vessels in one place. Kind of thin to medium sized, branching, plexiform vascular network. Now, this is not a vascular tumor, and that's an important distinction to make. Just because a tumor has prominent vascularity does not mean it is an endothelial tumor. And I think it's a really important skill for junior people here to learn to tell apart, are the vessels neoplastic or are they the background vascular network of the neoplastic cells, okay? And here you can tell at closer look, the spindle cells, those are the tumor cells, and yes, the vessels are part of the tumor, but this is not an endothelial tumor, right? Those are endothelial cells. Clearly, each vessel is distinct from the background spindle cells. Now look how bland these tumor cells are. Bland, very, very bland, fibroblastic appearing spindle cells with a myxoid or maybe edematous kind of pale background and a variable amount of collagen fibers, and then very prominent vessels. No atypia, very low mitotic activity, essentially none. So there's a closer look. Some areas can be a little bit more cellular and fascicular, but still very bland. And sometimes you will get some entrapment of adipocytes within this tumor. So the pitfalls here are a couple. I think cytologically this looks like a benign tumor, but you might look at this and say, this looks like it should be something, but I don't know what it is, right? It has a very distinct appearance. You ever have that problem? I do all the time, and then it drives me crazy when I can't figure it out. And what I love about this is one of my mentors was sitting with me at a USCAP meeting. Oh, it was in Vancouver, the very same. And it was, I hope he won't mind. He doesn't watch YouTube, so it'll be fine. Mark Edgar, who again, I respect hugely. He was in that meeting, and I want to say someone at the International Society of Bone and Soft Tissue showed this right around the time this entity was first described. And this is called an angiofibroma of soft tissue. Aren't there other angiofibromas? Yes, there are, like 6 of them, and they're all unrelated. So I'm sorry. I hate it, but I didn't name it, okay? But when they showed the tumor, Mark said, That's what that was. And he was so excited because he said he had seen one like a year ago and he remembered because it looked like it should be something, right? And then once it was described, so that resonates with me, that feeling of like, that should be a thing. It's a thing. I just don't know what thing it is. And this is one of those. So these are benign and beautiful. But the reason to know about them is, number one, the mistake you don't want to make is when we see lots of branching vessels, we think of myxoid liposarcoma, right? Now, this tumor doesn't really look much like myxoid liposarcoma if you've seen myxoid liposarcoma before. Also, myxoid liposarcoma is the vast majority are deep soft tissue tumors, usually in the deep musculature of the thigh of young to middle-aged adults. And in fact, if I see something I think is myxoid liposarcoma in any other site or any other situation, I do molecular to prove it. In the deep thigh of a young adult, I feel like myxoid liposarcoma is an H&E diagnosis. But in other locations, I want to prove with molecular. I've seen many myxoid liposarcomas. I've never seen one in the skin or the subcutaneous. It has been reported, but I have never seen one personally as someone who's done soft tissue pathology for almost 10 years. So that's one argument. Also, the vessels here are thicker than the vessels of myxoid liposarcoma. Myxoid liposarcoma should be the most thin, delicate, tiny little vessels you can imagine. They're like one endothelial cell thick. If you touch the vessel, it would just break apart. It's that thin. These vessels are thicker than that. And number two, myxoid liposarcoma, the vascular network is not this vascular, is less vascular. So smaller vessels and not nearly so many packed so closely. The other thing is that myxoid liposarcoma usually has round to oval nuclei evenly spaced from one another in a myxoid backgrounds. This tumor has more elongated spindled nuclei, and they're a bit more cellular with more collagen. So I have a myxoid liposarcoma. If you, I didn't tell you, but if you look on you probably noticed if you're on Kiko, where is it? If you look over here to the side on any of the cases, it shows my other posts. So I've got a page of all my dermatopathology videos, slides, sample reports, all of it there organized by entity. And I have the same down here for bone and soft tissue. So if you go here and you're like, I want to see a myxoid liposarcoma. So then just, hit Control F and search the page. Oh gosh. Touch typing. I have to relearn it. Yeah, there we go. Oh, I just have videos. I do have some digital slides. I just need to post them. But in any case, you can search, okay? But I do have a video here that shows in detail what the classic myxoid liposarcoma looks like, okay? And it with comparison, is quite different than this. The other problem is that this tumor sometimes expresses CD34. This particular case was mostly negative, but because of that, the fat entrapment, you could potentially think a little bit about dermatofibrosarcoma protuberans. Again, not really, but you might wonder if it was CD34, bland spindle cells, fat entrapment, you could consider it. Usually you're going to have a more swirled story-form pattern for DFSP, and I've seen dilated prominent staghorn or hemangioparasitic vessels in DFSP. I've never seen one that I can recall with these little delicate, prominent branching vessels. So I feel like this tumor doesn't look like much else. So if you see one, now you'll be like, oh, that's that thing. I mean, the first time I saw one, I was like, oh, that's angiofibroma of soft tissue. It just, nothing else looks like it really. Yes, sir.
Solitary fibrous tumor.
Well, that's a good point. Solitary fibrous tumor can have the variable cellularity, can certainly have myxoid change, and occasionally can have the little small branching vessels. So if you had any doubt about that, you could do STAT6. That's a good idea. To consider for ruling out, because it could look similar to this. Thank you. That's a great point. Very rare to see those in the skin, but we're talking about very rare things. So, rare stuff happens sometimes. Okay, I have the CD34 here. And the main reason here is just to highlight the background vascular network. So in this case, you can see CD34 is mostly negative with only some very focal staining, which would be an argument against solitary fibrous tumor here, but you're right that you could definitely have morphologic overlap. And you can see most of the spindle cells are negative, whereas the endothelial cells of those vessels are staining nicely. And look at how incredibly vascular this lesion is. So these tumors have a translocation involving AHRR. Show you. Did I put it in here? And NCoA2. So if you need to test for the molecular, you can, but I think once you've ruled out the other possibilities, it has a very distinct appearance. And I think I did include the other angiofibromas mentioned here, which would be cutaneous angiofibroma, also known as fibrous papule, which occurs on the nose of adults, very common, or rarely in kids with tuberous sclerosis. Totally unrelated, looks different. Nasopharyngeal angiofibroma in adolescent males in the nasal cavity with large vessels. Totally unrelated and looks different, but still called angiofibroma. And then cellular angiofibroma of the genitals, which is an important tumor to know because it is related to spindle cell pleomorphic lipoma. So I love to teach those together because they have very much overlapping morphology and they have the same molecular abnormality, RB1 loss. So spindle cell pleomorphic lipoma, cellular angiofibroma of the genitals, which is not nearly this vascular. It looks more like a spindle cell lipoma. Mammary myofibroblastoma, and a new one, superficial acral fibromyxoma, or digital fibromyxoma is the other name. All of those have overlapping morphology and loss of RB1. So confusing, frustrating names, but you can learn 4 tumors for the price of 1. So why not, right? Rarely do you get that in pathology. So when you do, take it, buy, okay? Buy it. Thank you, I like that. I don't know, my jokes that work on Americans, I don't know if they'll work on French audience. So you guys are my beta testing group to see how these jokes work in a wider audience. Just like my kids usually laugh at my jokes out of pity, basically. And I think my residents do the same. So I have 3 daughters, so I can make dad jokes now. I've earned the right to make dad jokes. Okay, so slow-growing thigh mass in a 30-year-old man. And Arnaud and I were talking over coffee, and he mentioned that maybe I'm a little too critical of the people who name tumors, because the terminology is frustrating for users sometimes, but is very difficult to find a good name for a new entity that everyone agrees with. And I don't have the experience of doing that. So it's easy to be a critic, right? And say, I don't like that name, but I don't know what I would name it either. But I do want to point out that it's challenging on both sides. So I appreciated that feedback. So here is a tumor in the deep dermis extending down to the subcutis. Very cellular. And as we go closer, we have sheets and some streaming fascicles of spindle cells with bizarre atypia, dramatic pleomorphism everywhere that you look. I would also point out, look at these. These are nuclear pseudo-inclusions. Now, that's not a specific finding, but there are some lesions that tend to have nuclear pseudo-inclusions, and this is one of them. So with the hypercellularity and the pleomorphism, in this case, I think the tendency would be to want to call this a pleomorphic sarcoma, right? I mean, to me, as a sarcoma pathologist, the degree of atypia here is in the range of that seen in undifferentiated pleomorphic sarcoma. But what I could not find is mitoses. So after counting, despite the pleomorphism, counting 50 high-power fields, I think actually in this case maybe I counted 100, maybe a little bit more than you need, but I think I found 1 mitosis or less, very, very low. And most pleomorphic sarcomas are going to have multiple mitoses in just 10 high-power fields. So whenever you see a soft tissue spindle cell tumor with pleomorphism, but very few or no mitoses, stop before you call it a sarcoma. Stop and ask yourself, is this one of those weird tumors that has dramatic pleomorphism, but is actually not sarcoma? And one of the clues is ugly pleomorphic cells, but very, very low mitotic activity. Okay, so that I find a very useful a tip in general for spindle cell tumors, that sarcomas usually have mitoses for high-grade sarcomas. Okay, the other thing is it possible to get undifferentiated sarcoma in the subcutis or skin of a young adult? Yeah, but pretty uncommon. I mean, you can see undifferentiated pleomorphic sarcoma in young adults, but usually they will be deep masses. It's pretty uncommon to have undifferentiated pleomorphic sarcoma in the skin and subcutis, okay? The couple exceptions of things in that category are in elderly adults on the extremity. You see myxofibrosarcoma, which is a pleomorphic sarcoma with prominent myxoid change, and they often involve the skin and the subcutis, but they will have mitoses, usually dramatic atypia, very infiltrative, and they are almost always in older adults. I've never seen one personally in a young adult. I think probably every case I've seen has been 50 years old or older. I don't think I've seen one younger than 50. Now, it has been reported younger, but I'm very skeptical anytime something is called myxofibrosarcoma and the person's middle-aged or younger. I'm always very cautious. The other time we see pleomorphic sarcoma in the dermis or subcutis is in elderly patient on the sun damaged scalp or face, head and neck. And those are a different pathway that we would call atypical fibroxanthoma if they're in the dermis only, or when it goes into the subcutis and a few other situations, we can call it pleomorphic dermal sarcoma. But they're also ugly and usually have obvious mitotic activity. But aside from those things, seeing an undifferentiated pleomorphic sarcoma, small and in the skin or subcutis, is relatively unusual and should make you stop and think, am I sure this is a sarcoma? Because it would not be a typical thing to see. So here, the pleomorphism there's a few clues. We have low mitotic rates. We had the nuclear pseudo-inclusions that I mentioned. Let me go to the PowerPoint. I have the pictures of the best areas. Somewhere. That's the atypia. And then here, there are nuclear inclusions. There are foamy cells, xanthomatous cells. Sometimes there is some hemosiderin pigment. So those are all clues to the diagnosis for this really rare and newly described tumor. Now this here's immunohistochemistry for CD34. Diffusely, strongly positive. And in case you're thinking, could it be a vascular stain, a CD31 and ERG would be negative here, okay? I want to also point out something that is a practical tip that I think a lot of people don't pay attention to. Notice that the dermis is normally positive for CD34, okay? So CD34 is not a specific marker. It stains vascular tumors. It stains many fibroblastic tumors and some fatty tumors. And it's most helpful, I think, when it's totally negative is the time I find it most helpful, or when it's strongly positive in one of those tumors that should always be positive, or almost always, like dermatofibrosarcoma protuberans. The vast majority will have diffuse CD34, except for fibrosarcomatous ones. And this tumor, which is kind of defined by its CD34 expression. But just remember that the normal dermis should have a lot of CD34 staining normally, okay? But here we see that the tumor cells are diffusely CD34 positive. And then also, here's pancytokeratin. And it's very focal, but there's some very weak, wispy staining in some of the tumor cells. There's also some background mast cells, but see, there is some tumor cell staining just focally with pancytokeratin. That's a very common finding in this tumor. So this tumor is known as superficial, CD34 positive, fibroblastic tumor. And I'll try to not be too critical of the name, but and also because Sharon Weiss, my mentor, who I respect deeply, was one of the people who helped describe this. The one thing I would say that I wish were added in the name is something to indicate the dramatic pleomorphism, because the pleomorphism is a constant feature of this tumor, and it is CD34 positive, but it's very ugly, and yet it has a very good prognosis, okay? These are rare and newly described. The key is the paradoxical lack of mitotic activity in contrast to the dramatic pleomorphism. And they are diffusely CD34 positive, and they usually have some degree of keratin expression. It's often patchy or focal. And I think they can have a little bit of desmin too, if I recall. And they tend to be on the lower extremities of adults. They tend to be in the skin and subcutis, and usually about 5 centimeters, but it can range a bit. And I think about only 30 or so cases have been published. I've only seen, I think, 2 cases in practice that I've recognized. And there has been one example that had a metastasis to a regional lymph node, but no one so far has died of this disease. I can't remember if it was this patient or the other one, but one of the patients we had, for a complicated reason involving the person's profession, they did not want to have a complete excision, which is normally what I would recommend, negative margins, and their tumor did recur after a year or so. As far as I know, they're still doing well, but I suspect they had a recurrence because they didn't get a negative margin, but they did not have metastasis as of the last time I had checked. So it seems that this falls into that category of low metastasizing potential, kind of that indeterminate range of tumors that are not really fully malignant, but maybe not entirely benign. They sometimes rarely can metastasize. But I think the really important thing is to recognize that this is not undifferentiated pleomorphic sarcoma. The prognosis is much better. These patients don't need radiation therapy probably, or chemo or anything like that. And for the patient to know you have something rare that we don't fully understand, but based on our limited knowledge, you're likely going to be okay. That's a much better situation than you have a high-grade sarcoma, right? So I think that that's an important thing, and there have been a few papers about this that you're welcome to read about. It's I've not published the 2 cases I've seen, but maybe I should eventually. And yeah, this particular case I think did have less than 1 per 100 high power fields. It was just hard to accept. I was like, there's got to be a mitosis somewhere. And I kept looking and looking, and it was very low. So another tumor that's kind of like this, the same scenario, looks a bit different, but it has pleomorphism with low mitoses, is pleomorphic, hyalinizing, angiectatic tumor, or FAT, P-H-A-T, because in English, P-H makes an F sound, so FAT. That's another tumor that is very atypical cytology, but very low mitotic rate and has an excellent prognosis. So those are important to keep in mind and consider. Okay.
So they were diagnosed as sarcoma before the description of this?
I think probably so. Yeah, I mean, I don't know, but I suspect because there wasn't really a category. It's an ugly tumor. I imagine they were called sarcoma, NOS, or undifferentiated pleomorphic sarcoma, I suspect. I don't know for sure. I mean, they are clearly quite rare, but, and the other thing, I can't remember if I put it in here. Maybe not.
They are pleomorphic, there are no specific rearrangement.
So that's a good question. So there is an entity is PRDM10, PRDM10, and there have been tumors that look like this that have an abnormality of PRDM10, and the WHO 5th edition soft tissue book suggests that maybe these are closely related or that they represent a subset. I wonder over time if we'll recognize that maybe this is not purely one entity. Maybe there are a couple of things that fit into here, but I think it is a worthwhile tumor to know about because it can get confused with sarcoma and yet behaves much better. So that's kind of my thought. Any questions? I mean, I have questions, but I don't know how to answer them. But it's an unusual combo of strong CD34 and focal keratin, And when I have when I have reported these, I put quotes around the name. And I tend to do that sometimes with tumor names that sound descriptive. Because we use descriptive terminology in pathology, and it's important to help our surgery or treating physician colleagues know, I recognize that this sounds like a name I just created today, but it's actually the proper name currently for this tumor. And I do that even with things like atypical lipomatous tumor, which is a name we've been using for quite some time, because I had a surgeon once call me, and they were not a surgical oncologist, not a cancer surgeon, but they said, so this is like a lipoma with atypia, right? And I was like, no, not exactly. And in the old days, that tumor was actually called atypical lipoma for a while in the 1980s by Harry Evans. So again, I can't complain that people don't understand, but so I do try to use really clear, like this is the name for well-diff liposarc when it arises in the extremity, because it does take a couple minutes to write that comment, but right away I can tell the treating doctor, this is what this means, this is what I want you to do about it. And I give treatment recommendations pretty often in my reports. I don't know what the tradition is in France. In the United States, some people do that. Some people never do that. I'm pretty bold, okay? I mean, look, I gotta wear a belt buckle from Texas. My wife is a Texan. You know, Americans have plenty of flaws, but we are bold, and that sometimes is good. Sometimes. Je suis désolé. What can you say? In any case, maybe I shouldn't have gone there, but it's late in the afternoon, and I'm just freely associating ideas. But the point is if I know about a tumor, like a soft tissue tumor, I was like, I know more about this probably than the treating physicians usually. So I'm going to tell them, this is what I want you to do. And I almost never have received, maybe never, in almost a decade, received complaints. Because I'm giving them the chance to not have to go and Google superficial CD. What is this thing? I saved them time in their clinic. I was like, here's what it is. You should refer it to this doctor, or you should excise it, or don't do anything. It's going to be fine. And I've saved them time. Now, in tumors that I'm not as familiar with, I don't go into that direction. But I figure if it's something that I understand well and can easily explain, why not help the treating physician understand? Or times where I say, well, this is complicated, and usually I would excise it, but this patient is a 90-year-old woman, and it's on her foot, not this tumor, but something. I did that once on a chondroma of soft tissue in a very elderly patient, and it was on the foot. And it had pretty bizarre atypia, which is reported, but it's rare. But I said, I just don't think it's a sarcoma. And normally I would want an excision, but if they excise this lady may never heal from that wound because she's old and has poor vascular flow. So I put in the report, normally I would want this, but given the age and the morbidity, I think maybe the risks are worse than the benefits. And the surgeon called and left a message and said, thank you, that really helped us make a decision. And I was like, because sometimes I think I waste all this time writing these comments and no one cares. No one reads this. I think I'm helping, and they're just like, what? Okay, it's cancer, whatever. And so when I get this once in a while, someone says, it made a difference for the patient, I'm like, worth it. So I don't know. That's how I feel. Thank you. You guys are a great audience. I really appreciate it. Okay. The last one, and then we can do some rant. You can tell me an entity, and if I've got a slide, I'll show you, or I'll pull some stuff, whatever you want. You guys paid for 6 hours of time. You're going to get it, okay? Every last drop. I'm running on fumes here. I'm almost out, but I'm going to go. Okay. The subcutaneous trunk mass in an adult. I don't even remember what this case was. Oh, that one, yeah. Well, this is a tumor I still have not fully wrapped my head around, and I kind of suspect it's because we don't really know yet how to wrap our head around it. So the reason I want to show this again is, and this is maybe the most challenging case in the whole series, because I don't know how to teach this, because it shows so many different things, and perhaps that's one of the clues. When I see all these different disparate morphologies, I think about this tumor. This is 5 slides, all from the same mass, okay? Here we've got kind of cells that are in short fascicles with prominent collagen in the background. There may be some scattered, slight pleomorphism, like a little bit larger cells, but not dramatic hypercellular atypia. This is not as atypical as that last case I showed you. It's a hypocellular, but the jeu right? Plump, juicy. I also say juicy. I don't know if it's right, but one of my students said, what does juicy mean? And I was like, je flux. It means fat, plump, okay? You know, in pathology, we use lots of classic words to describe how things look. But sometimes those classic descriptions don't work with my brain. I'm like, that's not chicken wire. I like to complain about chicken wire because people say, chicken wire vessel. Do you guys know what chicken wire is? Do they have such a thing in France? It's a metal, fence. It should be perfect hexagons in a repeating pattern. I've never seen any tumor have perfect. I'm a very concrete thinker. That's what my psychiatrist wife says. I'm not very good at abstract thoughts. I'm a very concrete. It should look exactly like it says. So I've never seen chicken wire anything. So sometimes it's okay to defy the classic tradition of how something was taught and find the word that works for your brain. And that's why I like to use lots of different descriptions in case one resonates with you. And that's something Mark Edgar, again, my mentor, he did, the words he used to describe morphology. I was like, oh yeah, that's exactly what it looks like. It resonated with my brain. So when I teach, I try to use lots of different words in hopes that one of them will click with your neurons. Okay, so here, same tumor again. Now we've got some inflammatory cells in it. We've got some fat entrapped at the edges. Bundles of kind of ropey, look at that wavy, see? Ramen noodles. Ramen noodles, that's collagen. It's not neural, but it gives you that neural feel, okay? Makes it seem neural. Here's an area that was more myxoid. And unfortunately, I apologize for the section, but this area showed the fat trapping the best. I mean, that is like the fat trapping you see in dermatofibrosarcoma protuberans, right? Morphologically, this tumor doesn't quite fit for dermatofibrosarcoma. The cytology to me is too plump. Usually, dermatofibrosarcoma protuberans is very thin, very stretched out, thin cells. So here's the fat entrapment. Here, look at those fascicles, kind of almost a herringbone or chevron. Chevron? Okay. Pattern a little bit, and a myxoid background, perivascular collagen hyalinization. That area does look quite like a neurofibroma, right? Kind of slightly curved or buckled or S-shaped cells with delicate myxoid and collagen in the background. And then there we've got collagen bundles. I mean, all of these different morphologies in the same tumor is so crazy. And that area looks almost fibrohistiocytic, right? Plump histiocytoid cells and a slightly swirled and storiform backgrounds. Same thing there with prominent lymphocytic infiltrate in this area. And then here with some scattered pleomorphism, okay? And I don't, unfortunately, have the immunohistochemical slides for this case, but what it had was an unusual combination. It was positive for CD34, had patchy but real expression of S100. And now remember, S100 staining scattered rare cells in the background, that's not positive. That's background dendritic cells, which you're going to find in almost any tumor, especially in inflamed tumors or skin tumors. And sometimes those cells, Langerhans cells and other dendritic cells, can be so abundant that people will see them and think that it's a tumor that's S100 expressing. I've seen people mistake things as melanoma because of prominent dendritic cells in the background. But a key there is if you do SOX10, it goes away, right? So here, there was real tumor staining for S100, but SOX10 was negative, which argues pretty strongly against a neural tumor or a melanocytic tumor. So putting all of this together, one tumor that has this mixture of features is a relatively new group of tumors that have been referred to as NTRK rearranged spindle cell neoplasm. And so this is an emerging entity, which means the story is not yet finished and will probably evolve. And I imagine that some of the things that fit into this category will eventually develop their own unique names, and we'll have probably several tumors that come out of this background. It's maybe a bit of a wastebasket right now, but not totally. There are tumors that have been described, some of the tumors described as lipofibromatosis, like neural tumor. Lipofibromatosis has herringbone-like pattern of fascicles and fat entrapment, and people have described tumors that looked like that and had a neural appearance and S100 expression. And so some of those seem to fit now into this NTRK category. And there have been a range of features ranging from low-grade tumors, which appear to behave in a benign, indolent fashion, to ones that are very atypical and look like sarcoma, and those seem to behave like sarcomas. So it seems like in these tumors, we don't have, their behavior is based on their morphology. If they look low-grade, probably it will behave well. If they look high-grade, probably it will act like a sarcoma, regardless of the fact that it has an NTRK abnormality, okay? So you can use the pan-TRK immunohistochemical stain as kind of a screening test for these, because they can have abnormalities of NTRK 1, 2, or 3, and then you can proceed to do molecular testing if needed to try to subcategorize these. The reason it's important to know is, number one, they're tumors that otherwise I would look at and say, I don't know what this is. So now when I see a spindly tumor with any of these features and I see some CD34 and S100, then I think, maybe it's NTRK. So sometimes I'll stain for it and I don't find it, but I try to look for it now that I know it's out there. And the other thing is that because we now know that there are drugs that can be used to target some of the NTRK fusions, targeted therapies, that when we have one of these that is in the malignant end of the spectrum, knowing about this may be helpful in defining a targeted therapy drug. So again, this is a tumor that I'm only teaching about because I've seen a couple of them and I'm looking for them, but I am not an expert on this tumor. I don't know, there are some people who may be, but I am not. But I wanted you to be aware of it since it's a new and evolving entity that's out there. And I definitely think they're hard to wrap your head around because they have such a wide range of morphologies. And I suspect, again, it's because probably this is not just one pure entity. You know a lot about NTRK. Is this something you've encountered? Or no?
I don't do much soft tissue, but I work a lot on NTRK tumors. And what's interesting is the pattern of staining is very complex and can be sometimes associated with the subtype of fusion partners. For example, MYO5A will be different from ETV6 in terms of one will be nuclear. ETV6 and TRK3 will be nuclear. You can have different patterns of staining that is going into complexity because it's going to be the 5' partner of the fusion is going to be different, and there's lots of possibilities. And the type of staining can be, and the morphology of the tumor, for example, for Spitz tumor that have a MYO5A and TRK3 fusion, they will look like schwannomatous tumors and have a cytoplasmic stain. And ETV6 and TRK3 will have more epithelioid cytology and have a nuclear stain. So I think there's lots of things to discover. And NTRK, what is really interesting is that they have sometimes very different morphology, even in the melanocytic group for NTRK3, the example I gave.
Interesting.
So there's going to be a growing level of complexity with the subpartner differentiation.
So that's kind of like with ALK, right? With ALK1, the different staining patterns sometimes indicate a certain fusion partner, I guess.
So that is also true with ALK. For example, there are some partners that are systematically negative by IHC. For example, this is something I will try to publish, but I have some cases that are always the same partner and always negative. So these are false negative by IHC. that you need to do with. They have the same they have maybe slightly different morphology, but not that much. So there's a lot of complexity linked to the partners that will make headaches probably to people, because this is really getting into another level of complexity with all the different partners.
So while you have the microphone, let me ask you, how often do you see tumors that are NTRK rearranged, but that are negative on pan-TRK stain? Is pan-TRK a very sensitive screen for TRK fusions or NTRK fusions, or are there some that are negative?
So,
because I've only had it for a short time, so I don't have much experience with it yet.
I don't know if this is also for soft tissue, but NTRK1 usually is so strong you do not need to put the slide under the microscope to see it's positive.
Okay.
And NTRK3, you always have to look very carefully, because they can have some background light stain, and I will go to fish conformation, and many times it will not be confirmed that have this weak staining. This is probably also linked that the pigmentation can have induced this weak staining. So that is some complexity that is linked to melanocytic tumors that maybe you don't have in soft tissues. So these antibodies are not easy to I think I say to people, if you have only the antibody but you don't have the fish, sometimes you're going to end up in a position where it's going to be complex, because you're not going to be able to finalize your vision of the molecular status of the tumor.
Yeah, so far I've used the pan-TRK as a screen with the idea that if it's positive, I'll send it out to do molecular to prove what it is. But I was wondering how good of a screen it is in practical usage. So I'll have to do some more reading and see over time. I mean, I think that just like with any immunostain, you read and you learn what the literature says it's supposed to do. And then in real life practice, sometimes there's more nuance, right? Stains are the very best and most specific the first day that they're published. And then things, come closer to reality, I think, over time, right? As we get, even stains that I've published where I really liked it at first, as I've used it over the years, I've thought, well, I've seen exceptions. I've seen times it didn't work as well, or it was harder to interpret than I had hoped for. And it's just a tool, right? Just like molecular is a tool that helps us to sort out things. But in the end, we have to critically think about these cases. So be on the lookout for this, and consider that this next time you see a unusual tumor that has kind of neural features, an S100 positive, SOX10 negative NTRK. Thank you for your comments, Arnaud. And that is all 16 cases. And now it's freestyle. Whatever you guys want me to teach you, I will do, or I will find some things. So do we have any audience requests? And that includes you at home. You guys can request. If I don't have it, or if I don't want to teach it, I'll pretend I don't have it. And then usually I don't upload anything. If I don't want to teach it, I'm like, no. Like alopecia, I have very few alopecia biopsies in my collection, except for really classic ones, because otherwise it's really hard, and I don't like it very much. So we saw talk about nail melanocytic lesions. Oh, no. I'm very sorry. I definitely do not. I find those to be among some of the most challenging, frustrating specimens to deal with, because they're really hard to section, very difficult to interpret, melanocytic lesions of the nail. Is that something you deal with a lot, Arnaud?
I do sometimes, not that much, but...
When I have them, I actually send them out to someone like Beth Rubin, who is a nail guru in California, or Adam Rubin, unrelated, both Rubins, spelled differently, both like nails, but not related at all. It's something about the name, but they're both nail gurus. I find nail pathology in general to be really challenging, because there's a lot that has to do with the sampling and where exactly you're sectioning. And I really struggle with those specimens. And if you're in general practice, I recommend don't make that pain for yourself. Make that pain for someone else. Send it out to the expert, right? They love it. They want to do it, but maybe not Arnaud unless he wants it. You send it to one of those other people who love the nails. But yeah, it's one of those very difficult. And I saw sweat gland tumors. Oh, well, yeah, we can do that. Let's see what we got. Here's another mucinous carcinoma. I kind of think of it as a sweat gland tumor, really. This is like the best one of all time, right? Every time I tweet it, it gets like 200 likes. Because, I mean, look at it, right? And this one didn't have a good in situ component, but a really great example of the sea of mucin and the nests floating in it. And again, not very much atypia, right? Usually pretty uniform in the nuclear appearance. This one's pretty cool. Something you don't see very often. So a basaloid tumor, but not a basal cell carcinoma. When you come down in here, you see very sharp, punched out lumens, some secretion inside, some blue myxoid material, and if you're lucky, you'll see kind of a reduplicated basement membrane appearance, but the very sharp, circumscribed, punched out spaces. So I think this fits well for a real, true example of adenoid cystic carcinoma. Very rare to see as a primary in the skin, but it does happen from time to time. I have seen one example, which I think maybe going to be presented at the American Society of Dermpath by one of our residents this year. But an example of an adenoid cystic that looked classic for adenoid cystic and merged with an area that looked more like spiroadenoma cylindroma. Really, I'd never seen another one like that. Very interesting case. So in the salivary gland, adenoid cystic carcinomas are problematic because they tend to be infiltrative, have perineural invasion, and can really cause problems for the patient. In the skin, the behavior is indolent usually. They do need excised with negative margins. And the other important thing is to make sure that it's not a metastasis. Now, I've not personally seen a skin metastasis from a salivary primary, but I think it's rare enough that it's worth probably having a head and neck exam to make sure they don't have an occult salivary gland tumor. The other thing is if this is anytime you have a salivary gland tumor or a sweat gland tumor that is on the cheek or preauricular area or even the neck, always think, could this actually be a salivary gland tumor growing up into the skin? And so then you can do imaging or physical exam, have a ear, nose, and throat otolaryngologist see the patient potentially, just to make sure, because the treatment implications are different. So in these tumors, though, once you've excluded metastasis, the behavior is very good and indolent for these in the skin, different than in the salivary gland. So this is as opposed to, basal cell carcinomas often get cystic change, what we call adenoid change. I don't know if I have one scanned. But in adenoid basal cell carcinoma, the cystic spaces are usually very irregular, filled with mucin, kind of all sorts of different sizes and shape, whereas in true adenoid cystic carcinoma, very sharply circumscribed, punched out, like perfectly round, usually, and sharply bordered by an area of pink kind of cuticle around it. Okay, it's an adenoid cystic. Oh, angiolymphoid hyperplasia with eosinophilia. I think I do have one of those. This is a very nice example from even low power, right? When you've seen this, you put this slide down, and the very first thing you think of is angiolymphoid hyperplasia with eosinophilia. The other name that's been proposed for this is epithelioid hemangioma. Now, as we've progressed in our knowledge, there is a thought that there are probably kind of two different things here. There's probably a true neoplasm, epithelioid hemangioma, that often have FOS-B abnormalities. And then in the skin itself, there are probably things that are reactive, that have prominent vessels, lymphocytes, and eosinophils that probably are non-neoplastic. So there's the WHO goes into that a little bit, but I think there are a lot of overlap morphologically, and it's worth knowing the most classic examples that you see are like this, I think. And this is, you can see this is a big damaged vessel, usually an artery. The temporal artery or branches of the temporal artery are one of the most common places to see angiolymphoid hyperplasia or epithelioid hemangioma. And the tumor often arises either in the lumen or in the wall of and expands out into the surrounding soft tissue. Okay? Here you can see it's kind of a lobule of cells pushing outward. The endothelial cells are very plump, geflu, and epithelioid, and so much so that sometimes they look more like nests of epithelioid cells rather than like vessels with lumens. When you do an immunostain for a vascular marker, it can sometimes help highlight that you really are dealing with vessels that are just with very plump, large endothelial cells. You can see like like here, see? That's a little lumen. It's just almost totally squeezed in to obscurity by the endothelial cells. Here's another right here, see? See how plump and large the endothelial cells are? Let me show you another area. This one, the lumen is more obvious, but you can see that the cells are large and push into the lumen. They will sometimes have endothelial vacuoles, which is a feature that's common among endothelial cells that are plump and epithelioid, often have cytoplasmic vacuoles to some extent, okay? So we often learn about that in the context of epithelioid hemangioendothelioma, which have the blister cells, the little vacuole with the red cell in the lumen. But you can see vacuoles in epithelioid hemangioma, aka angio-lymphoid hyperplasia with eosinophilia. You can see it in spindle cell hemangioma and others. Most of these cases will have, in addition to the plump vessels, the vessels are often arranged in little lobules, and then there's a brisk inflammatory background with numerous lymphocytes, sometimes with germinal center formation, and that's what these large atypical guys here, many of these are probably germinal center B cells. You can also sometimes see reactive lymphocytes or immunoblasts, which will be CD30 positive. You tend to see those can be very prominent in the background of this tumor, this process. And then eosinophils are usually present, sometimes numerous. There's lots of eosinophils here. But I want to point out that this is a really nice example because the lymphocyte inflammation and eosinophils are so abundant and robust, but some cases have very sparse inflammation and only scattered eosinophils. So recognize that not every case of angiolymphoid hyperplasia will look this lymphoid, okay? Sometimes they're much more subtle. Here's an area where the lumen of the damage, see, look at that muscular wall out there of the vessel. The lumen is crushed, and you can see those same endothelial cells that are very plump and epithelioid lining the lumen. And there, look, the little vacuoles too. And an important point to recognize about these, there's a closer look too, is that they can sometimes have really cellular, very atypical appearance, and particularly in one location where you don't want to make a mistake, in the penis. Epithelioid hemangioma of the penis can sometimes be very atypical and cellular and can lead to misdiagnosis as angiosarcoma with disastrous consequences. So before you diagnose an angiosarcoma of the penis, maybe get a consult on that one. I still feel very, very uncomfortable with that scenario because of obviously the very dramatic risk of what's going to happen to the patient with that kind of diagnosis. Numerous eosinophils here. And I've not used FOS or FOS-B staining for these yet, but I don't have access to that yet in my lab, but FOS is supposed to be very helpful for some of these. They don't always have it. And there's a kind of a growing number of endothelial lesions that can have FOS or FOS-B related fusions or immunostaining. So that's angiolymphoid hyperplasia. They can be one or sometimes multiple, often violaceous lesions. And again, the temple is a very good site for this. Okay? Yes?
What is the relationship with the Kimura disease?
Oh, with Kimura disease. So that comes up a lot. And I struggle with Kimura's disease because I've never seen a real life case personally. I think of Kimura as having more of a lymph node predominance, right? Really arising within a lymph node. My understanding is they often have more neutrophils in the background, but I've not encountered Kimura, so I never have been able to really wrap my head around it. So that's a good question. I think of it as more of a hematopathology disease, and this as more of a soft tissue pathology, even though they do have some overlap. So there was a really good tweet about that a while ago, but I've clearly not memorized it. Kyle Bradley is an excellent hematopathologist who was a fellow at Emory when I was a fellow there, and he tweeted a nice chart about that. Let's see if we can pull it up. Twitter will have all the answers for us, don't worry. This is like the best example ever. Although I saw a really good one this week. And I was very excited, and my residents are like, is it really that like uncommon? I was like, yes, it's really rare, and I get excited to see it. So this is another tumor growing out of the lumen of a blood vessel. Here's a vessel here, a thick-walled muscular vein probably. We probably have a bit of a valve of the vein that we're seeing there. I always like when I see valves, it's kind of cool. And then here, I mean, it always looks very scary to see any sort of tumor growing into the lumen of a vessel or out of the lumen of a vessel. So it's good to recognize that there are a variety of benign entities that can have intravascular growth, and that by itself is not always indicative of malignancy. So this tumor has, from low power, a biphasic appearance. We've got area here with large, dilated, cavernous channels, and then over here, a very cellular zone. So the cavernous channels are relatively similar to what you'd see in a cavernous venous hemangioma or venous malformation, right? Nothing too specific about them. The key is in the cellular areas, and what you have is a mixture of spindled and epithelioid endothelial cells packed closely together into what looks almost like solid sheets in here. Sometimes you get little slit-like or crack-like blood-filled spaces, which could call to mind Kaposi sarcoma, right? But Kaposi sarcoma, look at this. We have a circumscribed subcutaneous nodule. That is not the usual pattern of growth for Kaposi sarcoma. Almost all of the Kaposi sarcoma I've seen has been in the dermis. Maybe it went into subcutis, but starts in the dermis, with the exception of ones that are in lymph nodes or organs, something like that. But a solitary circumscribed subcutaneous nodule, to me, is not typical presentation of Kaposi sarcoma. And then over here, see, look at the spindle cells, and then these plump but very uniform and bland, kind of more epithelioid cells. And if you stain those, they'll all be positive for vascular markers, with also some negative cells in between that probably represent the pericytes, the modified smooth muscle cells that are present around most vascular channels. And this is my favorite part. It looks like little tiny baby fat cells, doesn't it? Little adipocytes, but it's not. Those are endothelial vacuoles clustered together, and they look like entrapped fat, but they are not adipocytes. Those are endothelial cells, and these vacuoles compressed together look almost like fatty tissue. And it's very characteristic. This is a spindle cell hemangioma, okay? In the old days, this was called spindle cell hemangioendothelioma because they often arise as multiple lesions in the same extremity. And Dr. Weiss published one of the landmark papers about this in the 1980s. And then in the 1990s, they went back and looked at that same cohort of patients, and none of them had metastasis, and none of them died, and no bad outcomes. And so they recognized this is a benign lesion that just has multicentric growth, probably related to the fact that it is present in vessel lumens. And so it can be multifocal. And because of that, it can be multifocal. So there has been debate in the past over, are these truly neoplasms or are these some sort of vascular malformation? And in more recent years, we've recognized that there is a genetic abnormality in these lesions in most cases. And that is mutation of IDH1 or IDH2, isocitrate dehydrogenase, one of the Krebs cycle enzymes. So I learned all those Krebs cycle things in med school, never found them useful until now when we're finding more and more tumors that have weird mutations of Krebs cycle enzymes. Like, why? I don't know. It doesn't make sense to me, but it's kind of cool. So IDH mutations in most of these, which is evidence that they probably represent true neoplasms. And I've actually seen cases where patients have had multiple different vascular tumors in the same extremity over decades of their life and never had metastases or death, and they were actually spindle cell hemangioma. So it's important to know because the multicentric growth is scary. Clinically, multiple tumors in the same limb makes you think of cancer, with regional kind of metastases marching up the limb, but that's not what's going on here, okay? And they are sometimes associated with Maffucci syndrome, which is germline mutation of IDH genes, which gives you predisposition to multiple enchondromas and sometimes chondrosarcoma, as well as spindle cell hemangiomas. So just look for the little mini fat cells. I think it's such a fun little feature. Spindle cell hemangioma. This is a case that taught me some very important lessons. This was sent in by a colleague who's a good dermatopathologist. And this is from I can't remember was it nose? Papule on the nose of an 80-year-old man. And my colleague had done S100 protein or SOX10, one of those. CD34 was negative, S100 was negative, Desmond was negative, P40 was negative. So we've done the usual panel of markers you might consider for ruling out, for looking at atypical fibroxanthoma versus melanoma versus spindle cell, squamous cell carcinoma. But there's something about it didn't sit right with me. And I don't know if it was that it was kind of more epithelioid, almost nested a little bit. And I'm not used to seeing that in atypical fibroxanthoma. And I was like, I just don't feel right about this being atypical fibroxanthoma, despite the fact that all the stains have been negative. And then here's the clue, very subtle. So I'll show you the immunostains. This is ERG, E-R-G, diffusely positive. And you can see it's not really quite so sheet-like as it looked. It's actually forming little nests and infiltrating in between the dermal collagen. Where's the other piece? Oh, there's no other piece. Ah, there it is. And then here you can see maybe a little bit of vascular channel formation, but really each of the spaces is filled with cells. So very challenging. Here is CD31. Blazing. Very, very positive. And here you can see vessels lined by atypical CD31 positive cells. And now, CD34. Staining only the background vessels and completely negative in the tumor cells. And this is one of several cases I've seen of CD34 negative angiosarcoma. So I do not like CD34 as a vascular marker most of the time because of this. So no vascular marker is totally perfect, unfortunately. The difficulties, and I've got a little write-up on this if you can refer back to if you need to later. It's right here on the Kiko website. So this is kind of my, I'm not going to read this all to you now, but my summary of how I kind of use vascular stains, okay? So ERG is very sensitive. I have not yet, knocking on wood, not yet seen an ERG negative vascular tumor. I'm sure I will eventually, but I've not encountered one yet. But it's not specific. ERG stains lots of things. It can stain prostate cancer, it stains epithelioid sarcoma, that new spindle cell thing, EWSR1 SMAD3, and sometimes AFX will have patchy staining, not diffuse strong, but kind of patchy, weak to moderate ERG staining. CD31 is very sensitive, but it is not quite as crisp and clean sometimes. It will stain histiocytes, usually with weak granular staining, but in a tumor that's very inflamed and has a high background histiocyte concentration, CD31 may not be the best choice because it will be dirty. It'll be hard to read. And what I want as my normal internal control when I'm looking at a vascular tumor, the tumor cells should be as strong as the background blood vessels and should be, if you have to ask, is this enough erg? The answer is probably no. No, it's not. Like you should, when you have an angiosarcoma, you put down the erg or the CD31 and you're like, whoa. You're not like, well, it's a little focal. No, let it go. That's nothing. It will be blazing. Knock your socks off, as we say in America, I think. I don't know where all these sayings come from. Like that, right? Good enough to be the control tissue. All right. And then so CD31, is good, but it will be a little harder to read sometimes. Also, Kaposi sarcoma, to my surprise, sometimes is CD31 negative. And there's a really nice paper here that was written a few years ago about why that is. That human herpes virus 8 actually downregulates expression of the CD31 molecule, which I thought was really fascinating. I realized because I was trained in the era of HHV8 immunostaining, we had HHV8 ever since I was a trainee. So if I wonder if something's Kaposi sarcoma, I don't do vascular markers. I just stain it for HHV8. And if it's positive, it's Kaposi sarcoma. Easy. But in the older days, like the 90s, there was not that. And back then, before anti-HIV therapy came around, and I thought this was a very poignant explanation that Omar Sangueza from Wake Forest, he's really interested in vascular tumors, and I interviewed him a few years ago for the American Society of Dermatopathology. I've done some interviews of really big name, famous dermpaths, so they're all on the American Society of Dermatopathology YouTube channel. You should check them out, not because of me, but because these people I interviewed are just these legends, and they told these wonderful stories. I learned so much. But Omar said, and I loved it, he said, well, before, in the early days of AIDS, there was no cure for AIDS, there's no treatments, and if you gave someone a diagnosis of Kaposi sarcoma, you were giving them AIDS, basically. And that was kind of a really eye-opening moment of how significant and scary that time was, and that it became very important to separate out Kaposi sarcoma from mimics, because it meant something very bad at the time. Whereas now it's more of a chronically managed disease outside of the setting of AIDS, not curable, but usually not something that's going to kill patients. In this setting, there are some exceptions in, patients with immunosuppression or African endemic type, which can be more aggressive sometimes. But in any case, the point was I didn't realize that, and I thought that was an interesting article if you're curious. And CD34 can sometimes be a nice stain for vascular tumors, but recognize that it can be negative. So in difficult cases, sometimes I'll use all three of those markers, but I recommend not using CD34 as your only screening marker for vascular tumors. It is dangerous because I've seen cases like this. And angiosarcoma is an aggressive tumor. Sometimes it's treated in unique ways, different from other tumors and other types of sarcomas. It has some very unique things about it that needs to make sure that it's not missed. Okay? Let me see if I have another thing. Oh, yes. Forgive me, it's not Dermpath, but since we talked about it earlier. Myxoid liposarcoma. Now that's myxoid liposarcoma, right? Look at how social distance is respected. It's a joke that we wish were so not true, but it occurred to me one day when I was teaching during the pandemic, and I was like, oh, social distancing, it's been right there all along. Myxoid liposarcoma, no, but it's true though. And the reason it's important is there are other tumors that have round little cells and a myxoid background, but that tend to make clusters or cords or chains, like chordoma or myoepithelioma or extraskeletal myxoid chondrosarcoma. Those have cells, usually bigger cells, and they stick together. The cells leave each other alone, and they stay spaced out, okay? And these are the vessels of myxoid liposarcoma. Look at that. It's like one endothelial cell, and that's it. That's the vessel wall. One endothelial cell. The vessel lumen is only big enough for the cells to go like single file. Like sometimes they look almost like a rouleau formation, right? say, right? In myeloma, you know, where the little stack, like, oh, look, see? It's like one endothelial cell at a time, single file line. That's how small the vessels should be in a myxoid liposarcoma. And you will see lipoblasts, but there'll be these little tiny cute lipoblasts, little signet ring cells, or maybe bivaculated lipoblasts, not the ugly pleomorphic lipoblasts that you expect to see like in pleomorphic liposarcoma. You will not see those. All the cells look the same. And why is that? Because it's a translocation sarcoma. All of the cells have the same abnormality, which is a fusion between the FUS gene and the DDIT3 gene, which was formerly called CHOP. And sometimes it's Ewing's instead of FUS. And that's a good general rule for soft tissue pathology. If something has a Ewing's gene rearrangement fused with something else, one day someone will probably discover, well, occasionally these have FUS instead of Ewing fused. And the opposite is true, because FUS and EWSR1 are similar types of genes and they perform a similar role. So a lot of things that have FUS will have an alternate fusion that has Ewing's and vice versa. So it's a general good rule. So if you're taking an exam for the junior people out there, your guess should always be, if it's a molecular and soft tissue, guess EWSR1. That's usually right. And if it's an EWSR1 thing and they say, what's the alternate? Guess FUS, because that will be right. All right. Do I have a pseudomyogenic hemangioendothelioma? No, but I have that in the stack of slides to be scanned when I get back from this meeting, because it's an important topic. I do have a video. Oh, that's not done yet. It's also on my to-do list. I've recorded it with my fellows and I've not edited it yet. Pseudomyogenic hemangioendothelioma is an important tumor because it's a vascular tumor that does not look like a vascular tumor. It's solid epithelioid cells with no vascular lumens, and yet it's a vascular neoplasm. Very strange, kind of too complicated to go into without having some pictures to show you. So, but you can go and look that up, pseudomyogenic hemangioendothelioma. Okay, that's myxoid liposarcoma. They often have these big pools of myxoid change. Sometimes it's so prominent like this. People have said that it looks like pulmonary edema, like in an autopsy lung, right? That's been described as the pulmonary edema pattern. Is only a subset of cases have it, but it's a useful clue when you see it. And this case actually has also, in addition to the conventional typical pattern, areas here that are much more cellular and round blue cell in appearance. And when you start seeing the cells get bigger and touching and overlapping, this used to be called round cell liposarcoma. And the new terminology is high-grade myxoid liposarcoma. I still usually put in parentheses, formerly known as round cell, because people understand that term. It's the higher grade version of myxoid liposarcoma. And usually when you have the round cell, I've occasionally seen times on a core biopsy where it really looked like a round blue cell tumor. But if you get enough of a sample, usually you will find in the background some myxoid change, some little tiny vessels. And if you get a big enough sample, you'll see areas in the background that look like obvious myxoid liposarcoma. So only on a small biopsy, sometimes it can present a mimic of Ewing's or some other round cell sarcoma. But usually, if you get a big enough sample, pretty easy to tell you're dealing with this. And also on imaging, myxoid liposarcoma has pretty distinct imaging radiographic characteristics. So oftentimes a good skilled musculoskeletal radiologist will know, oh, this is probably a liposarcoma, because they'll see the fat signal and the myxoid signal on an MRI scan. Okay, another question is trichoepithelial carcinoma. Is it a true entity or a variant of squamous cell carcinoma, as proposed by Dr. Ricania? Well, who am I to say? But I'll say that when I started practice, I called some things trichoepithelial carcinoma. And then people ask questions, and now I just call them all squamous cell carcinoma. There is a type of squamous cell carcinoma that has prominent clear cell change and palisading, and it does have some trichoepithelial characteristics. But I think for practical purposes, I think it's a morphologic variant of squamous cell carcinoma. I think the most important thing is I don't want people to confuse that with the benign trichoepithelioma. So I don't use that terminology anymore, but I do recognize there is a morphologic thing that looks like that. I don't know that it really matters to call it that versus squamous cell, but I'm also not an expert at the level of Dr. Requena, so I don't know if I'm right. Let me see. What time are we supposed to stop?
It will be okay.
Look, I can do this all day, but I don't want to keep this poor captive audience, longer than needs be.
I think everyone is happy. Okay.
You got your money's worth? Okay, good.
And we will thank you for
Oh.
the cases for.
Avec plaisir. Merci beaucoup. The hospitality and friendliness of the French people has been magnificent. I love visiting here, and especially to share a day looking at cases with a room full of wonderful pathology colleagues. So I wish you all the best, and you always know where to find me, on Twitter, of course, or anywhere else. If I can do anything to help, please let me know. Thank you.